Hi, my name is Peter. I'm an emergency medicine resident from Denmark, currently based in Stockholm. I'm affiliated with these organizations, Younger Danish Society of Emergency Medicine, IDEM, Akut Medicinen, which is a blog on emergency medicine, and EMCC, Emergency Medicine Core Competences, based in Lund, Sweden, where I'm an instructor. Today I will be talking to you about probabilistic neurology for the emergency physician. In these lectures I like to put out a disclaimer, and besides the organizations that I previously told that I'm affiliated with, I have also been fortunate enough to make a book or be a co-editor of a book, Den Akutte Patient, the 4th edition, which is one of the books in emergency medicine in Denmark. I also like to just say that I'm not a neurologist. Please follow the guidelines of your local hospital and your local system. I have a huge passion for neurology, and I have worked in neurology for a few years in different settings, both in Sweden and Denmark, and in also in pediatric setting and in a psychiatric and a geriatric setting with a lean towards neurology. So I do have some experience in this area, and it is my clinical area of highest interest. I also like to put out this slide. I'm standing on the shoulders of giants, which is a quote from Isaac Newton. Everything I'm going to tell you and everything I hopefully can teach you about emergency neurology is something that I've learned either from very, very talented mentors I've had in neurology and emergency medicine, or otherwise. So these are, most of these are not my own ideas. I picked it up from clinical experience and books and the FOMED community. So I will thank these people for my achievements today. So if I love neurology so much, why am I not a neurologist? Well, I love neurology in the emergency department. It's very clinical. You can do most of what you need to do with the patient with a good history and a clinical examination, and not many areas of medicine or surgery are capable of saying that anymore. So that's one of the things that has drawn me to neurology. I like to think in a Bayesian way, a probabilistic way, and the reason why I'm not a neurologist, and I haven't chosen that path even though I've thought about it, and even though I might subspecialize in it later on, I feel like when I worked in neurology that I was not interested enough in the final diagnosis of the patient, but I was more interested in the beginning of the patient's journey. This is not a critique of my colleagues in neurology, but probably more advice of my own, that I like to think probabilistic about things, and I felt like chasing down what I would think were zebras with a lack of a decent pretest probability was something that I was never drawn to that. And Henry Marsh describes neurologists like this, like neurologists like strange and obscure diseases and sometimes untreatable, which they find deeply fascinating and which they collect like rare butterflies and report in their journals. Henry Marsh is a neurosurgeon and wrote this book called Do No Harm, which I would highly recommend reading. But that kind of sums up why I'm not a neurologist. I don't like this butterfly collecting kind of way, and I might not, for that reason, be thorough enough to be an outpatient neurologist. This lecture is a long lecture where I'll try to go through my pearls in neurology, and these are the sources that I think for an emergency physician are good to know about. At least all the ones that I could fit in one slide. I've marked the ones that I think are especially important, and you may take a look on your own time. I will show these 3 books though. For different reasons, I will recommend these as if you need some books on this topic and you are interested in this area as well as I am. The left one by Jonathan Howard is a new book delving into the cognitive biases and cognitive psychology of our decision making, just like we know from Patrick Croskery and others in emergency medicine talking about system 1 and system 2 thinking and the errors that we might come across in our decision making. It's case based and it's a great read, so I highly recommend it. The middle one is one of my favorite books in neurology, and it's a simple, very short book. I hate Made Easy series of books, but this one is a book that we often get recommended in neurological departments in Denmark. It's besides just showing you how to do a clinical exam, it's full of like small pearls of wisdom that are really essential in neurology. I highly recommend this one. And to the right, we have a book by Daniel Concilla and Gunhild Valdemar. Concilla is a German neurologist working in Copenhagen, and he made this book with Gunhild, and it's a very, very clinical book showing you a great approach, and a lot of the stuff that I will show you today I have from this book. It might be a bit heavy for some emergency physicians, and there are other alternatives that are that might be considered just as good. Then I'll also shortly tell you about narrative medicine, because I believe that learning about any topic in neurology or medicine in general is supported by narrative medicine. So I would recommend these books, and I will show you some of them through the lectures, especially Susanne O'Sullivan's books. Yeah. So finally, what am I trying to achieve today? So this is Neuroland. Neuroland is a land where neurologists are, and usually we as emergency physicians are not allowed over to Neuroland. But what I wanted to try to give to you today is a key that I will keep in the corner of each of my slides to signify that this is a very, very important slide if you want to go to Neuroland and you want to be able to distinguish the time critical features of a undifferentiated patient presenting with suspected neurological disease. So up front, I want to show you the approach that I'm going to go through. This is a key slide. So first of all, always do an ABCDE no matter what. I will not be focusing on the ABCDE, the critical patient. I will more lean towards the non-critical patients, as I feel like these are more difficult for us in emergency medicine. The simple structure is the history of the clinical examination and the imaging. No big surprises here. But I will show you this triangle showing that you have to put emphasis on the beginning of this triad of things that you might do. History and clinical examination are the most important, and you might, from some papers, subtract that, find that 80% of the diagnosis that you can make, especially in neurology, can be made by just paying attention to the history and the clinical examination. the back of your mind, through when you meet a patient, I want you to think about these, especially these three words here. You want to think about, is there a lesion at all? Could it be meaning that all patients with a neurological presentation doesn't have necessarily a neurological injury? It might be medical, or it might be a functional, which we will delve into. If there is a neurological injury, we want to know where is the lesion, and that is something that we achieve through the history and the clinical examination. And if there is a neurological lesion, we want to know also what is the lesion, and that is also a history thing, but something that we often want to get help with by imaging or other tests. And the final one, what to do about the lesion, is something that I will delve into in the end of this lecture with through cases. I want to emphasize that this is a Bayesian thing. I will present to you with a Bayesian way of doing this. This is often something that is implicit in our curriculum, but rarely talked about explicitly. And I will try to talk to you about this explicitly so that you can understand why we're doing what we're doing and why we are weighing certain examinations more than others. This is a central picture also because this is the picture I want you to have in your mind with the where is the lesion. Well, I'll come back to that. This is the disposition. I'll begin with a pearls and principles, kind of a mindset, a bit fussy beginning here. And after that, I will delve into more details about the neuroanatomy and the approach to the neurological patient in the ED. And in the end, I will go through cases. This is a marathon lecture, and it will take several hours. I recommend that you either jump back and forth, depending on what you're interested in knowing about, or take it from the beginning to the end, but in several sittings. Okay, first of all, pearls and principles. So pearl number one. In the emergency department, we see all the noise. So when we approach a patient with a possible neurodeficit, our EMCC course usually teaches that we'll go through the danger. Is there any abnormality? Do we need to do any kind of ABCDE kind of management, resus of the patient? But if not, then we'll go to these things where we want to gather data, and we want to know where and what the lesion is, and so forth. In medicine in general, in emergency medicine in general, 10% of our patients are up here, maybe 5% even in certain settings, and maybe a bit more in other settings, depending on your center. But most of our patients are down here. And it's important to notice that most patients that we see in a non-tertiary center and a non-invasive center will be down here, because the patients with the very obvious neurological findings are not at our place. They've been driven to an invasive center. So there's a filter before they even come to our emergency department. So we actually get the patients that are harder to work up because they might have more noisy symptoms, so to speak. Okay, principle number 2. Who is the neuropatient in ED? I hate the term calling patients neuropatients or medical patients or surgical patients, because the philosophy of emergency medicine is that we see undifferentiated patients. It might be a nitpicking thing, but I like to say that we have an undifferentiated patient, and we might have a concern or we might think that this patient has a neurological cause of their symptoms, And what kind of patients are these? What kind of groups of patients will we think of when we think neuro? Well, it might be a spectrum here, from going from medicine-ish to neuro-ish to definitely Neuroland. And it can be argued with these presentations where they fit, but I've made it like this just to give you an overview as well. So you have your fever and neurodeficits. Usually that will be more medical than neuro, but yeah. And then there's fatigue. You have headache patients. You have dizziness and vertigo patients, and cognitive disturbance patients like memory deficits or stuff like that. You have your loss of consciousness, young and old, which are different groups. In terms of causes, where the young are usually intoxicated and the old are more likely to have neuro causes. Then you have the transient loss of consciousness or spells or episodes of some sort. And you have your binocular visual disturbances becoming more and more neuro-ish. And in the very, often very high signal to noise, this is neuro, are the sensory and motor deficits, and maybe also the hypo and hyperkinetic movement disorders, but we don't see those as much in the emergency department. Those are usually outpatient. So I'm not saying that these are medical and these are neuro. It's Bayesian. It really depends on what kind of story are being told, but if you have as we will see, if you have a visual disturbance, for instance, it's often more ophthalmological than neurological, depending on the nuances of the story and the examination. As well as headache is for many reasons not necessarily a neurological disorder. So I think we should be very reluctant to put patients into groups like this, and we should be quite open in thinking that what we think of as a neuro presentation might just be medical or anything else, and any doctor should be able to, any doctor in the emergency department should be able to work up these patients and then ask for help if they are very much towards Neuroland. Okay, this is one of my pet peeves: hardware, software, and mimics. So when you have a patient presenting in the emergency department or anywhere else, they might have some deficits like this, shown in black here. And I want you to think about the fact that it might not just be neuro, it might be other stuff as well. And this is what we might call hardware, software, and mimic problems. Let's go through these. So the hardware problem is the classical default thinking of a doctor. If you and the patient as well, because if you think about a patient coming to the ED having these lesions, you will think, well, where in the nervous system is there a problem? The nervous system is really a very forgiving thing if you know the neuroanatomy, or at least know the basics of the neuroanatomy. Because if you know that there's a lesion here, then you can know what kind of presentation that would achieve. I call this the one-to-one. It's like the nervous system is a wiring system of electrical circuits, and if you destroy one part of the nervous system, then you will get a downstream problem from that particular lesion. So it's very logical like that. That is a hardware problem, and that is what we usually talk about when we have for instance, a stroke. Then there's a lesion in the nervous system, giving a logical downstream symptomatology presentation. one of the challenges when you have a hardware problem is that how to fit this presentation into one lesion, or maybe it's several lesions. So is it an Occam's razor problem where you have one lesion for all of the stuff, or do you have a Hickham's dictum problem where you have several lesions or several problems for these? This kind of thinking assumes that the patient is a good storyteller, assumes that all of what we are shown is true, and for several reasons, which I will not delve too much into in this lecture, we cannot always trust the patient's story depending on how we attain the information and depending on how the patient is acting. So we should always put confidence intervals on our certainty of the symptoms and the certainty of the information. Not that we should distrust what the patients say, but we shouldn't always think that what is seen and what is there is what it actually is. So when we think about the brain and the nervous system as a circuit board, then there's something that is left out. A computer cannot function without its software, and in the nervous system we do get software problems as well, where there's no problem with the nervous system, but the things that modulate the nervous system are having problems. And what is it that modulate our nervous system? Well, that's our emotions and the psychosocial aspects of life, and we often neglect thinking about that as a cause of the patient's neurological deficits. If you want to know, I will now go through this, and I will recommend these books about it as well, which are easily read. It's All in Your Head by Suzanne O'Sullivan, and The Lost Art of Healing, which is a Bernard Lown. He was a cardiologist who recently died. But he like this entire philosophy is not just neurological, but it's the philosophy of the biopsychosocial model and the philosophy of the dimension of psychology in somaticization of symptoms. So you might think what I would call the how of these somaticization diseases or illnesses, as more appropriately called. How can that be so psychosomatic? How can you have a weak arm, or how can you be blind from a psychosomatic lesion reason? Sorry, how can this happen? I mean, how can you have a seizure from something that is emotional? I mean, I agree. It is hard to explain this, but nevertheless, I will try. And people have explained this much better than I, and that's why I'm recommending the books. Well, I'll try to explain the how of how can someone have massive lesions on presentation, but massive apparent lesions on presentation, but actually have a emotional or psychosomatic cause of it. And how can we become better at spotting this in the emergency department? So first of all, I want to just remind you that there is a mind-body complex. The mind has a huge influence on the body, and the body has a huge influence on the mind. We might, if you're not convinced about this, Suzanne O'Sullivan takes up the example of laughter as a way to explain that we have an emotional response with a phenotypically bodily reaction. You feel happy or you feel something, and then you laugh. And much in the same way, we can have physical symptoms or physical reactions from emotions, and And these can be negative as well as positive, meaning that it might be laughter, but it might also be something as dissociative seizures and other kinds of dissociative neglecting symptoms like sensory symptoms, like not feeling your part of your body, and even positive symptoms, or like symptoms of gain or movement can be attributed to this, like with the dystonias. So the model I want you to know about here, and you might already know about this, is if you have someone coming in and telling you their head hurts or their back aches or any kind of presentation, actually, we would always want to think about the complexity of how the symptoms origin, the biopsychosocial model, and I've talked about this earlier. I will not go into details about this, but I'll show you the lecture where I'll go into these things in detail. But we have a responsibility in emergency medicine to try to also be aware of the psychosocial aspect of this. So how can this happen? Well, an analogy might be like this: that if your body is like a balloon, your entire like being is a balloon, then when you over time put pressure on it, stress or emotional stress or physical stress, beyond what we would call eustress, but like over stressing, and especially chronically, and you might not be able to cope. You don't have the good coping strategies. Then at sometimes the balloon will burst, and how it bursts are different from different people. But if you put pressure on many people, especially without coping strategies, or then you will have a burst, and the burst might be somaticization of symptoms. It might be somaticization of emotions. Sorry, it might be depression. It might be alcoholism, or something trying to, like, something gives, and if we just talk about the somaticization, then traditionally we put somaticization into like 3 categories. A lot of this stems from the Freudian school, and in the 1800s Paris school of neurology, where we have somaticization being an emotion, and emotion becoming somatic symptoms. And they might be pain symptoms, they might be fatigue, and they might be what we call functional neurological disorder, being sensory deficits or weaknesses or seizures, or pseudo seizures, dissociative seizures, stuff like that. And notice that the pain syndrome is not necessarily only headache. It might as well just be chest pain. All of this is general to it's general to all of medicine. It's not just neurology. But the thing about neurology is that you can actually test for it in ways that you cannot easily do in other subjects. In other areas of medicine, and that's why many patients may go through a lot of investigations, and if they have small findings on baseline, then we will attribute their problems to that finding, which might not have anything to do about that particular disease. A classical example would be doing an MRI on a patient with back pain. Well, we know a huge amount of people have a prolapsed disc on MRI when you test it like at baseline, but there's very little correlation between the symptoms and their pain. Their pain and the findings on the MRI. But we are medicalizing the patients doing in this process, and it might be better to actually know about this kind of these biopsychosocial processes and trying to talk to them about that instead of putting them into the somatic group. It's important to know that we all do this. This is not something that is only the psych patients or only the patients that are weak or vulnerable or whatever. We all somaticize, and it's a very common human thing to do. And I might explain it like this. So if we have if you have someone here and they have a baseline, like in their health, how they feel and how they carry themselves, there's a baseline. Some days we feel better and sometimes we might feel a bit worse, but in general it regresses to the mean, as we say, the red line here. But the mean might change over time if you're chronically stressed. You don't have coping strategies to manage that stress. You will, over time, your baseline will be pushed more and more towards a more ill version of yourself. You will feel worse. And with stress, I feel I hate the word stress, but it's I'm talking about very wide stress. So it might be you don't eat, you don't sleep, you don't exercise, you don't have a good emotional communication. These kind of chronic bad stress kind of things. Over time, talking usually months and years, you might infinitesimally, like small incremental steps, move up here, and it's important that this is infinitesimally, because you don't know about this from day to day. You might, if you record yourself or someone meets you at day one and maybe a year later, then they might see something. They might spot your blind spot, but you usually can't do that yourself. So when they are presenting in the emergency department, a lot of patients where we think a stress-related illness, or there might be a big psychosocial aspect of their presentation, it's usually a bad thing to ask about. Well, are you stressed? Because the patient hears it as you're negligizing their symptoms for something psychological, and when they do studies on this, they don't find that patients are aware of their stress, and that's exactly the thing. That's exactly one of the contributing factors to why it's coming. The stress is coming out as a somatic symptom. So so this is a catch-22 problem, and how we help the patient with this in the emergency department is a challenge, and I will try to give my answer to how to do this. But it might not just be the emergency department, but also the culture and the way we talk about health, not just being somatic, but also psychosocial health. Sorry for the Danish slide, but I couldn't find a English one for this. It's important to know that this somatization tendency is a spectrum, and we're all on this spectrum, as I told you before, but some patients are more prone to moving up the ladder faster, but in general we are all the same. We can all move up this ladder from bodily sensations every day to having passing symptoms where we might contact the healthcare authority, also the healthcare system. And then some people get stuck going into what we would call functional neurological disease, or functional any kind of disease with maybe chronic pain or chronic IBS, anything like this. And I will stress this, that when the patient is meeting the healthcare society, the healthcare system, that is different depending on stuff like accessibility, the culture. What do we view this kind of symptom that they're presenting with as a disease or something serious or not? I mean, if you have stress and it comes out as chest pain instead of headache, well, then you're more prone to seeking the healthcare system, and the healthcare system is more prone to getting you that coronary angio, and you're more prone to being medicalized and not being talked to about the psychosocial component. And why some patients present with certain kind of somaticization symptoms is complex, and I'll give you my. It's usually unknowable from a doctor's perspective. It takes a psychology and something like a background interpretation to know that. But just know that patients can, with the same background problem, being chronic stress or lack of coping strategies or other psychosocial problems, they will it's quite random how they actually present, and that's why it's important for us to know about like all of our presentations in emergency medicine might be this patient, and it's really common. Okay. So how might this happen? Well, in neurology especially, I've talked about, well, you have a background with life experiences, and then you will have some kind of trigger usually. There might be a trigger event, which is why you should not just say that it's psychosocial. There's a trigger event. Maybe it's somatic trigger. Maybe there is a somatic trigger event. Maybe there's a psychosocial trigger event. But there's something, because of the background, that keeps the patient in, like this trigger event doesn't go like pass as it would for patients that are not prone to this at this moment of their life. And this might be the reason why they become FND or FNS. And then the problem is that there's a maintenance cycle here, which we as doctors are part of. So when they present at the hospital, they will, if we are not good at talking about this aspect of illnesses, then we might be a huge part of the problem, because if we are not talking about these things, then they will become more uncertain. Often they will get anxiety about their symptoms, then they will go into this, what we might call the cognitive diamond. They will do body scans. They will become more aware of their own symptoms, as we all do when we are worried about a symptom. And sometimes they will go into even avoidance behavior. They might not even, so it might be chest pain, or it might be headache, or anything. They think they have a serious chest condition. Well, they will go into this maintenance cycle, becoming more and more scared, and going down this path of which will inevitably end up as a functional disorder, maybe pain, maybe fatigue, maybe a neurological symptom. But and we as healthcare professionals, especially in the ED, because we are often the first point of contact, are very, very important, and how we communicate with the patients are of the essence. Okay, I just wanted to show you that this is something that we, this is an example of dizziness, and if you want to delve into this, there's a good book by Stone and Hamlet and Aminoff here. But this is what we call the cognitive diamond, which is taught in cognitive psychotherapy, cognitive behavioral therapy, and where your thoughts and behavior and your physiology and your emotions, they kind of they kind of play into each other, making this. Well, you feel faint. You might start at any point. You might have emotions about you're afraid of feeling faint because it might represent something for you. Your mother died from a stroke after feeling faint. Well, then you might get lightheaded when you think about these things, and your behavior will be affected by this. You will not do the things that you usually do because you're afraid of you're afraid of triggering these dizziness spells. And this will only get worse if you're not becoming aware of this cycle phenomena, and that is where we as healthcare professionals might help. So that was the how. How do we develop symptoms that are not so purely somatic, but with a huge psychosocial component? And that's what we need to know as physicians, I think. The why is usually what the patient wants to know. Like, why is this happening to me? Or as they sometimes might say, well, that's very well. That can happen to some people, but it doesn't happen to me. That doesn't apply to me. So and how do we respond to this problem of how does this fit with the individual? Well, my answer to this is that we should probably not in the ED delve into this problem. We should probably just tell the patient that, well, this is something that can happen. I'm not saying that it's happening to you in particular, but we need to always keep in mind that there is a biopsychosocial component of all diseases, no matter whether the somatic is very strong or the psychosocial is very strong. It's important to plant this seed, I think, but you don't have to convince the patient about it. In emergency medicine, we just have to rule out the time-critical condition and try to listen to the patient and then get them to follow up with someone who might be able to listen and delve into this. Optimally, it's a psychologist they need to see to teach them these things that I just taught you and how they apply to the specific patient. I think we can ease this. I think we can get to where we want to with the patients in the emergency department by having good communication skills, and I will show you how. So why, I mean, this is not traditionally taught in emergency medicine. Why do we even have to think about this in emergency medicine? Well, because these patients present to our emergency department, and if we do not think about it, and if we only think about the time-critical conditions, we might end up harming these patients, and that is contradictory to what we actually want to achieve. Cauda et al. Says this. Well, these simple techniques like good history taking and information can make an enormous difference to people's experiences of and trust in healthcare, and are in their own right a treatment for the functional neurological disorders. For example, in a cohort of people with dissociative seizures, 50% were regularly attending the A&E, and diagnostic explanation resulted in 74% drop in attendance on the A&E. So it's really important that we actually are able to talk to patients about these these illnesses, disorders. Okay, so I've shown this slide before, and now I've said, like, when the patient contacts the healthcare system, then it's a tipping point. Actually, it's a scale here, and we might tip the scales in the wrong direction if we're not able to communicate with the patient decently. They might lose trust in the healthcare system. They might go on to develop more. They might be more ingrained in their apparent somatic symptoms, and nobody's helping them. Nobody is listening to them. So they might seek out other doctors and doctors shop, but they might lose trust in their healthcare system altogether. And it's we might be part of this vicious cycle that they can go into. So it's really important to be able to be open about this and talk to them. try to validate them, try to listen empathetically, of course, in the setting of the emergency department and with our challenges of time-critical conditions in other patients. But yeah, we can do this, and I think we should. So we are the first contact, but might be the last if they don't. And just because we might be the last contact doesn't mean that their symptoms go away. They might just stop trying to get help for the symptoms, and lose quality of life for that reason. So okay, so how can we help in the ED? How is it that we might be able to help these patients in the ED? Well, first of all, I think we should look at ourselves as a culture, and yourself in particular as a person, how your beliefs are. One of these books on this topic by Harlett and John Stone tells this, like, to affected patients, whether limited by pain, subjective sensory complaints, abnormal movement, seizures, or some other disturbances of neurological function that is difficult to explain, i.e. it's not a hardware problem, it's probably a software problem. Their complaints are as distressing and disabling as when they arise from some recognizable organic cause. Indeed, these patients have the added burden of coping with medical ignorance, physicians' intolerance, the stigma often associated with the disorder that is in the mind, and the insecurity that results from the absence of a specific diagnosis with recognized treatment. We are, what they're saying here, that we are quite bad at, first of all, being aware that psychosocial symptoms can be as severe as like blindness or stroke-like symptoms, or a severe headache, or thunderclap headache, anything like this. So we are as a group quite ignorant, and we're also quite afraid of this, because we know that if we say the wrong words, then we might lose the alliance with the patient. If we say, oh, it's just stress, if we are in a disrespectful way trying to say what we think is true, then then we might lose them as well, and we might get a complaint, especially if they turn out to go down the road, get that test for the get that MRI, and it actually did show at a prolapsed disc, which they said was the cause. Confirmation bias is a huge problem in this, and the pressures on doctors is a huge problem in this. But I think we can become better at knowing our role in this. Susanne O'Sullivan in her book says this: if we really want the situation to improve on pain and functional disorders and somaticizing stigma, then we each have a contribution to make. There is room for change in all of us. Doctors should be less afraid of this diagnosis, more willing to confront it, and more compassionate to sufferers. Medical professionals need to stop placing this unqualified diagnosis right at the bottom of their list, instead of appearing as a footnote in medical textbooks. Psychosomatic disorders should be acknowledged as a serious diagnosis in their own right, but most of all, society, the general public, you need to stop regarding symptoms of this sort as in some way less real than those associated with other diseases. I usually tell my patients when they have some kind of movement that might be described as a seizure. Then I usually tell them this: we don't know what the cause of this is. It might be a seizure, or it might be what we call a dissociative seizure. We don't at this point know which one it is, but both of them is nothing that you can do anything about. But the treatment of those two groups are different. And that's why it's important for us to know which one it is. That's a kind of neutral way to talk about this, and to evening the playing field behind the somatic and the more psychosocial dissociative seizures. And especially saying that it's not their fault is is a very, very, very important piece of information. Functional disorders, somaticization is subconscious. It's not their fault. Of course, there are some, maybe very few, that are having what we call fastidious disorders, or Munchausen by proxy, or Munchausen's. And but I, as Susanne O'Sullivan in her book, and I, from my experience, also think it's a losing battle to try to find these. It's better to think, because that is the majority of the patients that are actually not faking any of these. They don't know what is happening. It's subconscious to them. It's not their fault. And through therapy, that is the purpose of the therapy, is making it conscious so that they can find, they can be aware of when they are in stress, or in whatever is their psychosocial pressures, and actually making it part of their awareness, and being able to stop the what they're doing, so that they don't have to go all the way into a dissociation seizure, or so I think this is really important, and that's why I'm using so much of your time on this. But because I bet you haven't heard about this before, or maybe not from an emergency physician. You shouldn't think of this right up front in the first patient you see, first time they come to the ED. You should always think of the biological, time-critical things first. I'm not saying that you should pick out everyone as psychosocial. I am saying that all diseases and illnesses have a psychosocial component, so it's always part of the picture. But in emergency medicine especially, we need to look at the biological thing first, and rule out the time critical things there first. But if patients present often, or if they have a very, very obvious psychosocial problem, which you might be able to examine, which I will tell you shortly about, then it's important to address these things. Yeah. It's important though to be cautious of. So what we might say when we have ruled out the biological component, and there's well, what is it then? Sometimes we find some kind of pseudo diagnosis. Well, it's musculoskeletal, or well, it's just a virus, and that is, I feel, not a good way to talk with patients, because they have had a virus before. They might have had musculoskeletal symptoms before, and either they go into this and try to like become this diagnosis. They want to, how do you fix that? And or they go the other direction, where they think like we're just not listening to them. They have serious symptoms, and we haven't been able to find what it is. And our purpose in emergency medicine is not to find what it is. That is part of the expectation management in your communication. But we should, in our when we send patients home, it's important to not to weigh our words wisely with these patients, and with all patients. Don't just say, well, it's normal, just go home. It's important to say, well, there's no time critical conditions here. I'm not saying that if your symptoms persist, then go to your own doctor or come back. We always welcome, so on and so forth. And you might talk about the biopsychosocial components of these and what they might be able to do, and so on. And there's a balance here, because I mean, some patients need to know, well, everything is normal, you don't have to worry about this. And some patients need to know the more nuanced answer. And how do you know which patient to give what kind of information? Well, that's art, I guess. That's the art of medicine. But I think a key thing is that if they feel like they've been listened to and their problem has been addressed, then you are more, then it's easier for you to say everything is normal, because they feel like, well, you have heard about everything, and I feel like everything actually is normal after I've been here to the doctor. But if you have not done that, or you have, and there might be very good reasons for why you haven't had time to do that, well, then it's important to maybe give a more nuanced answer. Okay. I talk more about this in this lecture called the Probabilistic Thinking and Headache, which is more of a lecture about Bayesian thinking and communication and decision making. So please check that out if you want to go into more about this. So I want to also stress this: you can't prove a negative. So if a patient has a primarily psychosocial problem, well, then you can't prove a negative. You can't prove that they actually have anything. Because there's nothing to find. But we all have some small abnormalities at baseline, whether it's in the head or in the back as prolapsed discs or whatever. And if you just do enough tests, we all doctors know that you will find something. And especially in non-neurological fields, like for instance, chest pain, a lot of us have like plaques in our coronary arteries. But if the somatization symptom that you present with is chest pain, and we are very afraid of chest pain for good reasons, because it is a heart attack is horrible disease, and we want to pick those up. But in the process, sometimes we might send patients to stress tests or other inferior tests that are more likely to be false positive than actually positive. And the end result will be that, well, you will get a coronary angiography, and maybe there is a small lesion that could be stented here. And I'm not neglecting the expertise of my cardiology colleagues. It's more the culture of medicine I'm critiquing here, that we are prone to wanting to be certain about the patient's symptoms, and there is no test for psychosomatic illness. That's communication, and that's continuous care, and that is alliance with the patient. And if we substitute that with tests, then we will sometimes lead the patient down this cascade of care where they will end up being medicalized and being patients, which no one wants to be. So you can't prove a negative. I will encourage you to communicate with the patient before doing tests blindly, but you don't know that. But you do know that already. Okay. Know how to approach an FND patient, a pain or a fatigue. They don't present like this. They present like chest pain. They present like headache. They present like weak arms or sensation problems, something like that. And how do we do that? Well, in neurology, I've told you that neurology is kind of unique for these patients because you can test your hypotheses. You can in ways that you can't in other areas, especially if they present with movement problems or weaknesses or sensory deficits. Because, as I told you, the hardware has a very logical, very distinct way of presenting. If you know the bigger pieces of the neuroanatomy, then you will know that, well, a lesion presents in a certain way, in a certain pattern. Of course, always with brackets of uncertainty, but in a certain way they will present usually. And if your patient presents in a way that is not consistent with just one lesion, or maybe more unlikely several lesions, well, then you should think about, well, testing these things. Symptoms, Susanne O'Sullivan's like say this, that symptoms that arise through stress and anxiety are produced in the mind and are dependent on what the sufferer understands about their body and their disease. So your patient with a left-sided headache might present also with feelings of numbness in their left side, and also feeling of heaviness in their left side. And the way that both the way that they describe their symptoms, but also the way that they do things in your emergency department when they're not when they're not formally tested, but when we are looking at them, they might be using their limbs in the same way as they would normally. That's inconsistent, and it's these inconsistencies that we are trying to pick out. And remember, it's not like we are trying to jump out at the patient and saying, "Ha! I saw you now." you didn't do that right, because they don't know. It's subconscious. That's the reason why they don't want to be in your emergency department most of the time anyway. They don't want to be there. So that's kind of the mindset I want you to carry with you here. There are several tests, like for leg weakness, there are Hoover's tests. There are different tests where you can try to distract the patient. I will not go into these, but I have blogs where I go into these on our homepage at Quit Medicine, and please look at the references for some of these. But the main thing is here, you want to find inconsistencies in the nervous system, and sometimes oftentimes it's good to consult a neurologist looking with you. And if you find them, actually it's good to show the patient and tell them, because it helps them to know why these things are not consistent with a lesion. Okay, so to bring this home about software problems, your mindset, it's important to have an open mindset, knowing that serious presentations like seizure-like symptoms, stroke-like weakness, and so on, and thunderclap-like headache can present in apparently can present looking just like the real thing, but not being it. And there are nuances in history and examination that can pick them out. Oftentimes you need to do the biological workup anyway, but when it turns out to be normal, or when it turns out to be very, very unlikely and you have a high suspicion of these things being maybe psychosocial, then it's important to talk to the patient about these things. It's important to manage your own prejudice in these things, and it's hard because we know these patients. We might know some of these patients. Some of these patients are very obviously in a bad way, trying to not being comfortable with coping strategies and so on. But a lot of these patients are normal patients coming in, having never been there before, and having apparently very serious symptoms. So it's all of us who can somaticize. Okay, the communication, I showed you the link to my video about communication, and a lot of these things are what is important. You have to validate their suffering, no matter whether it's biological or psychosocial, and address some of the illnesses as I described with dissociative seizures, where you tell the patient that, well, it might as well be the other thing, but you are not to blame for any of the causes of whether it's psychosocial or biological things. Somatization is unconscious. That's the thing about it. But we need to work up whether it's biological or psychosocial, and until we do that, we don't know, and we have to keep an eye out for both of them because the treatment is different. I say avoid, but be cautious, I probably should say, about the phrase everything is normal, because it's not congruent with what patients experience. I mean, they come with serious problems, and you say that there's no biological cause. That is not part of their culture. That is not part of the narrative that medicine sadly is giving us today. The doctors say I'm fine, but I have these serious symptoms that are invalidating to me. That's a cognitive incongruence with the patient, and we need to address the how, not the why, how patients can feel this way. But there's a balance. Some patients, if we do listen to them, and if we have validated their feelings and they feel like they've been listened to and taken serious, then oftentimes we might be able to say, well, I do think everything is normal. There's nothing to be concerned about biological wise, but it's something that we should check up psychosocial wise with your primary care physician or something like that. Be open about our uncertainties. We can never prove a negative, but many of these patients have been doing lots of tests, and there's diminishing likelihood that these that the cause of their symptoms is biological, but there's always a 0.1% or 0.001% or whatever, or maybe we are not in the right paradigm as we see with the ME CFS, discussion, what chronic fatigue syndrome discussion, where there's a huge group of patients feeling like, well, there must be a somatic reason for this, and we just haven't found it yet. And there's always this narrative going on with all of the diseases, and I think the treatment, or the best way of acknowledging this is like, well, there are uncertainties, but there is no quick fix about this, and no matter what, even if we are uncertain, we don't have that knowledge yet. So it's important to focus on the things that we actually can help you with, and also saying that it's very unlikely that there is a biological component and so on. But we have to be respectful about it. We have to be open about our uncertainties, and we have to manage the expectations always with the patient in the emergency department. And it's important. I feel like I'm no expert in this, but having read about this for a long time now, I feel like I am able to explain the how to many patients, and they often accept it. But there are pitfalls in doing so, and I think it's something that has to be practiced, and not all patients have to know the how. So choosing the patients to have this conversation with in the emergency department setting is also a skill. There are certain tests, and I have not shown you the tests here, but I'll encourage you to check out the links and the references that I've given you on this topic. And there's one thing though: if you have a high suspicion of psychosocial problems, and try to not order the tests, or try to at least communicate your concern with the patients if they're presenting for the X time. It's important, and it tells them that you actually care, and you might even explain that, well, the easy thing is just to order tests for you, but I actually care about your health, and I don't think that's the right thing to do. And if you are in a buckle and you need to order the test one way or the other, I will always try to put in a shared decision-making kind of conversation, saying that, well, what we're particularly looking at one specific thing here, which is highly unlikely, but I will order the test. But ordering tests is very there are brackets of uncertainty around all tests, and there might be an incidentaloma or like anything that doesn't necessarily explain your symptoms if that happens. It's important to like kind of do a pre-brief for these patients. And then I usually tell my patients to I will encourage them to, especially those who have seen several doctors in a short amount of time, see one doctor. Even though you stick with one doctor, the one that you like the best and have the best alliance with, so that he or she can write up all your symptoms and know about you. And if you have any symptoms that are new, then you can work up that biological component, but not, you need someone with an overview of you. If they don't, then because some of these patients have huge massive amount of you have to do massive amount of reading to actually know about these patients, because they've been so much in the system, some of them, and if no one in the emergency department can do that. So it's important to tell them that someone needs to be that person for them to become better. You want to know more about, or if you want to give the patient something, then there's this neurosymptoms.org made by one of the professors of this neurological topic, John Stone. And I often give them these videos especially if they have pain, but just to show them that a biopsychosocial component, it's important to know all of these components. I have in these blogs written about this topic as well, so you might check that out as well. Okay, So the take home of FND, I will just show it here and pause the screen and you can read it. But we have to know it as emergency physicians. Okay, that was a long talk about the software, but I think it's a really, really, really important problem that is hugely neglected in medicine, and that's why I wanted to bring it up. Okay, so we talked about when the patient presents, there might be hardware problem. It might be a hardware problem, like a lesion in the wiring, making a logical presentation with a symptom. It might be a software problem, as we just talked about. It might also be mimics, and we'll just quickly go through mimics. So mimics for a neurodeficit presentation. By mimics, I mean, well, we thought it was a lesion, but actually it's something that was either reversible or it was a medical cause disguising as a neurological presentation, or it might be both. So if some of the self-limiting neural lesions that we might treat as stroke might be migraine. Most migraines don't have motor symptoms, but if they do have motor symptoms, then it's important to consult a neurologist because it's atypical and sometimes it might represent something bad. Tots palsy, something that happens after your epileptic seizure. You might be weak in the arm. It's often hard to distinguish whether this happened before or after the seizure, and sometimes these patients do become thrombolized. Multiple sclerosis is like the common, it's like the chameleon of neurology. Everything, MS can present in a lot of ways, and neurologists are fascinated by this, but it's a huge diagnostic problem and a huge risk of overdiagnosis in the emergency department, thinking that all neurological symptoms can be MS. I would encourage people to consult neurologists before ordering that MRI, and only going by likelihood of this being something. Okay, TGA, transient global amnesia. The patient comes in, has total memory deficit of what just happened, but they have been doing something that is they're acting a bit strange, but they have no memory of what happened. They're in a bubble of a few hours. It's usually older males, but can be females, and on an MRI, if you do a quick MRI on them, they will have a lesion, but that lesion will go back. And the reason, and when they present to the emergency department, you can go in and ask them or present yourself, and then you leave, and you go in and present yourself again. And if they don't react to your second presentation, well, you're presenting yourself all over again, and they're reacting as if it's the first time. Well, then it's probably TGA. When they come out of this bubble of a few hours, then they don't remember what happened usually, but it's important they have been doing normal things, just a bit strangely, but they have been doing normal things in the bubble, and that's how you discern them from other kinds of diseases presenting somewhat like that. Maybe seizures or focal seizures or temporal seizures where they present, where they might be doing strange things, or hypoglycemic events, something like that, where they present doing strange stuff. But this strange stuff is usually lasts more than just a few hours, or more than and they're not doing good stuff like normal stuff. They might be going into the shower with clothes on, or they might be I don't know, something like that. And then you have seizures. Seizures, as I told you, can present it in a variety of ways. Usually, what is very important to know about seizures is that they're stereotypical. So they will usually present the same way always. You have one or a handful of seizures that are always presenting the same way. Usually have the same triggers. So it's really important to know that. And describe the semiology of the seizure. Like, how does it look? and that's how you usually can discern it from a dissociative seizure, but it might be hard. It's important in this group of mimics, central limits and mimics, and this is not an exhausting list, but it's important to know that these patients in studies, in relative small studies, but anyway, they are quite low risk of bleeding on thrombolysis, because many of these patients might end up being given TPA, and the risk of bleeding is higher if you have a lesion. So the patients that don't have a lesion usually don't bleed, and they have a lower risk of bleeding. So it's nice to know that if you're thinking about thrombolizing these patients, well, at least they have a much lower risk of the bleeding. Okay, then there might be no lesions, or what I call medical mimics of neurological presentations. And for muscle disorders, for weakness, it might be PMR, polymyalgia, rheumatic polymyalgia. Delirium, I've marked in red because it's so common that I hear patients being a bit confused, and then it's all right, and then they're confused again. This fluctuation in elderly patients. Delirium is so common, and the treatment of it is really important to know, and how to pick it up is really important to know for any emergency physician. Psychiatric and FND, well, metabolic is something that we often miss, especially hypokalemia, also usually presenting with proximal weakness. Wernicke's encephalopathy, B12 hypoglycemia. There's a huge list of these, but I'll just mark the few that I often that I often in my clinical experience have met. One I didn't show here was the hip fracture when they present with leg weakness. That is also a really common one. And then you have a combination of maybe medical and neurological, where so the combination here would be recrudescence is an important one. If you had a stroke before, and then you get an infection of some kind, or some kind of stress in the system, then you might develop the same kind of stroke-like symptoms that you had before. So, for instance, if you had a weakness in your right arm that was 2 out of 5, then over the next couple of months, you will gain some strength, and you will actually have a 3 or 4 out of 5. Then when you get an infection, it goes back to maybe 3 out of 5. Then this is highly suspicious of recrudescence. It's highly unlikely that you will get a stroke in the exact same area, making that lesion again. So it's the more likely thing is here that it's the infection that is actually causing this. That the scar in the brain is more susceptible to stress than the rest of the brain, is a way that you might explain this. I'm not sure that is the reason why, but we do see this recrudescence phenomena, and it's quite common. And these patients might be in risk of bleeding if you thrombolize them. I don't know that there are any studies on this, but they have a lesion, so they might be in that risk group. It's also important to know that if the strength I said was if the initial stroke was 2 out of 5 strength in the right arm, then if the new symptoms are total paralysis, like 0 out of 5 strength in the right arm, then I would be concerned for a stroke, because it shouldn't be worse off than before. It should be as bad or a little better, but worse than their baseline. Okay. You have the same with a lot of neurological symptoms, but Uthoff's phenomenon is classically known in MS, where you have a pseudo MS attack because of fever, where you get and these patients don't need the prednisone because it's the infection that you need to treat. And it's just a scarring in the brain and the CNS that is the reason for the symptoms. So then you have these, and I call these combination mimics, because they actually do cause a neurological problem. They are tampering with the nervous system, and some I highlight here is ischemic embolus. These are quite common if you have low flow state, especially, and you have some kind of low flow state being like maybe bradycardia, or you have a heart that is not beating as it should, heart failure, or something like that, and then you have a atrial fibrillation on top of that. Then there's a higher risk of this, like getting these emboli, usually presenting with a lot of pain, but not necessarily, especially in the older patients. And the ischemic embolus might go anywhere, but often to the limbs. Then you have your endocarditis, and I highlight this because if you thrombolize a septic emboli, then they usually bleed, and the patient, I've seen a few, not a lot of times because it's quite rare, but I've seen 1 or 2 patients sadly become much worse because of being treated with thrombolysis or blood thinners when they had an endocarditis and stroke-like symptoms. So it's a good pearl to listen to the heart when you have a neuro patient, to see if there's any new kinds of murmurs, and if they have a fever on top of that, then I would be concerned. Okay. And then aortic dissection, of course, can present with stroke-like symptoms if it dissects all the way up into the brain, or if it dissects other, cutting off other neural branches through the body. Okay, this is just a short list, and it's my own personal list. So please comment if you have any other lists you want to, or any other mimics that you usually use. If you want to know more about this, you use this Amen of Neurology and General Medicine. That is the Bible of the transition zone between neurology and medicine. Okay, so these are the 3. And I usually call this like, where is the lesion? And this is more like, there is no lesion. And when we go through my approach to the neurological patient in a little while, I will usually use where is the lesion. That is usually when I think that there's a hardware problem. I want to find that lesion, or that neurological mimic, and there's no lesion. That would be the medical parts of the mimics, or a software problem. Okay, so, and this, I just wanted to show you this is where that is on my approach. Okay, so pearl number 4, Bayes theorem, also known as there's no troponin in neurology, also known as high quality communication is the best test of all. Well, I've gone through this in this lecture, and if you are interested, then please look at that. I just wanted to show you quickly that what Bayes theorem is the concept of a test is only useful in the context of a pretest probability assessment, and we can use this fagans normogram to show this. You have the pretest probability here, you have your test here being shown in likelihood ratios, and then you have a post-test probability here. So if you have pretest probability of 5 and you have a test with a likelihood ratio of 2, then you will get a post-test probability of 10. So the probability goes from 5 to 10 if you use the test with a probability likelihood ratio of 2. All sensitivity and specificity can be calculated into likelihood ratios, and I don't think this is a mathematical thing. It's the concept of we cannot interpret a test without knowing the context, without knowing the pre-test probability, and that is essential. So every test has a likelihood ratio and an inter-rater reliability, and the knowledge of the test comes from other sources, right? So it depends on what kind of paper and what kind of population this test was actually conducted, and what kind of expert did it. We are going to talk about the HINTS test. It has a great likelihood ratio, but it was tested by an expert in Neuro Ophtalmology in the original paper by Cauda, and that is a problem when we want to apply it to our population in the emergency department, because I'm not an expert in neuro ophthalmology. I don't have all the fancy equipment either to do that. So I don't suspect that I can get the same likelihood ratios as they could. And that was also shown when they did the studies in the emergency department later on. Okay. If you want to, this was a really quick read through about the Bayes theory. If you want to know more about it, if you want a 30-minute video explained by one of the best emergency physician podcasts out there, then go to Broomdocs and search for Bayes, a Diagnostic Odyssey, and yeah, I've tried to talk about this in several videos and blogs as well, so you might check those out as well. And there's this one paper. There's a lot of papers on this, but there's this one paper that might that is great at just getting to the nuts and bolts of this, by Schechter. Okay, I just want to tell a bit about where do our knowledge comes from, like from the tests we're using in the Bayes theorem. So so you might have someone come and say, well, I'm doing this because I think it's a good test. Well, how do you know that it's a good test? Our rationale can come from three ways, as I see it, from three pathways. There's the rational pathway, where you, which we might call the physiological pathway. So, giving thrombolysis to a patient is reasonable because they have a blood clot, and a blood clot is destroyed by thrombolysis because it's a blood thinner. That's a rational argument. You don't have to see the patient in the clinical context to actually do that. You can say that, well, all patients with a stroke should have should be thrombolized unless there's a risk of bleeding. So that would be the rational kind of approach. It's the what you might call the physiological argument of how you know. Then there's the traditionalism and pragmatism. Like, well, I don't know why I do this, but I do this because we've always done this, and that's an illogical way, but it's usually why we do a lot of things. And then there's the empirism, the experience kind of way, and that can be dealt into a systematic kind of experience, which is from studies, epidemiological studies, and that is what EBM is, like evidence-based medicine. It's taking a lot of systematic experience from a lot of patients, trying to do it in a systematic way, and then from these huge populations going down into the one patient. Thrombolysis in 13 studies did not show a benefit. So we should be cautious of using it, would be the argument in just the evidence-based way. Evidence-based medicine is a triad, as you know, and I'm just talking about the evidence leg of the evidence-based medicine here. And then you might have a unsystematic way, which is your clinical experience. Well, I saw a patient once that actually got better right away on thrombolysis, so that's why I'm using it in all of my patients. So these are the reasons why we are doing things, and there are problems with all of them. The rationalistic approach is usually, well, usually we don't have a nuanced enough paradigm. I mean, the rationalistic approach was what led us to bloodletting a long time ago, and because that fitted with the paradigm at that time, that we had to bloodlet people if they had an infection, and it wasn't until they did a study on it that they actually found that people actually die more doing bloodletting. So the physiological argument is prone to problems with paradigm problems, that we might not know the unknown unknowns. We don't know what we don't know, so to speak, and we might. Well, it makes sense that a blood clot can be removed by thrombolysis, but if if it's maybe it's an old blood clot, and that wouldn't be able to be removed by thrombolysis, or maybe there are collaterals that makes up for. There's lots of the physiological argument can always be twisted in a way to fit your own narrative, so to speak. So you have to be very strict when using the physiological argument. But oftentimes it's the only thing that we have. And sometimes we the psychosocial thing that we talked about just now actually also fits in here, but it's more weak, or actually it's viewed as more weak, as the culture of medicine is not usually used to talking about those things. So the rationality is really good. It can be used, and is used every day, especially maybe in anesthesiology, where they for lots of reasons can't do a lot of studies. But we have to be humble, because patients are complex and are not machines, and our paradigms are not complete. We have a lot of unknowns. Traditionalism, well, that's so we have to, and the problem with traditionalism is that it is illogical, but it well. And the problem with empiricism is usually that, well, there's lots of critique about evidence-based medicine. I actually did a podcast on this, which you can check out at the homepage. But many of the problems with emergency medicine evidence-based medicine is that, well, there is it's from populations going down to a patient level. It's you can't necessarily extrapolate from that, and well, there's a lot of critique, and I won't go into it anymore. And the clinical experience is always prone to errors. It's really important to use it, but it's always, you have to be humble about it as well, because it's unsystematic, and we might be prone to our own cognitive biases. The patient that we saw with stroke that got better might have been a TIA, might have been a TIA. The reason why I take all of this up is all of these things is what goes into guidelines, and guidelines are also well, frosted with conflicts of interest and industry sponsorship and so on and so forth. So this makes guidelines highly problematic as a standard of care, and we should always, as physicians, be guided by guidelines, because they are made by people who know a lot of stuff, but there's huge bias and huge conflict of interest usually in these. So we probably need to do another way of doing guidelines, where the physician is being advised by them, but not told what to do. I won't go more into that problem, but it was just to tell you that, well, tests and treatments are like the rationale of why we're doing stuff is not always clear, and it should be more transparent so that we can make up our own minds. So moving back to this, so communication, which I will be going into now, is very, very important. And it's something that not just happens when you take the history, it's something that happens all the way through, okay? And it's always a Bayesian approach that you have to the history taking. Collecting the data, I just wanted to show, like, a very thorough junior intern comes to you and says that his chest pain patient is Babinski positive. I mean, what now? So, well, that's the equivalent of doing a test without assessing the pretest probability. So we want to check what is the pretest probability of this patient having any kind of central lesion, and what is the likelihood ratio of a positive Babinski, and are we sure that this junior doctor can actually do a decent Babinski, and it's not just like just the movement that the patient does when stroking the foot. So there's a lot of uncertainty here, and that's how I would approach this problem. That's why the pretest probability assessment is so important, and the best way to assess the pretest probability is by a good communication. And this is told also in neurology. Like this is from Concella. The history is more likely to lead to the correct diagnosis than the physical examination. Therefore, as a rule, more time should be devoted to the history compared to the bedside examination. And in Geraint Fowler, remember that a spontaneously reported symptom is much more significant than one obtained on direct questioning. And if uninterrupted, patients usually listen, only talk for 1 to 2 minutes before stopping. Listen first, then clarify what you do not understand later. And I usually call this the good communication achieves two things at the same time thing. And I will not go through these slides, but I will ask you to, these are slides from my lecture on communication and headache and probabilistic thinking. I will urge you to go to that link that I showed you earlier on. I'll just show this as well, like the tests. In neurology, we usually go directly to the CT scan in many patients, where we should delve more into the pretest probability before. I just wanted to show you this, like these are headaches, and for headaches, the CT scan might be a good test for the bleeds, which I marked in green here. But for all of these orange conditions, we really need a good pretest probability assessment to know what kind of scan we want. For instance, a subarachnoid hemorrhage only has a good sensitivity and specificity if you do it within 6 to 12 hours and goes down from there. If you have a dissection, you want a audiography. If you have a CVST, a venous thrombosis, and you want a venography. So you need a bit more than just ordering a scan. So the CT scan is good if you use it properly. The white ones are the ones where the CT scan will not help you. So we need to, there is no test that can help us with the clinical judgment, is what I want to say. Okay. Moving on to my pearl number 5, the neurological exam they don't tell you about. Well, so in these next couple of slides, I want to tell you about some of my pearls in neurological examination. So we're moving to this area here. And first of all, I want to talk to you about screening versus focused neurological assessment. Some of the questions I often get is how much examination neurological wise do I have to do? And well, it's a question that is hard to answer. I usually think about this, the neurological examination like this. There are 6 areas that I want to examine, like at a basic level. You want to assess the higher brain functions. I usually deal like part them into these two here, and 2 from the head, 2 from the body, and 2 from the functional or gait system. And just my way of remembering it, you might have another way, but higher brain functions and cranial nerves, the head one, I'll do here. Then you have the motor and the reflex and the sensory, and then you have your functional ones, the coordination and the gait. And that's how I remember what kind of things that I had to assess, at least for having an entire system, a basic examination. But it's important to know that, well, you have your focused and you have your screening examination. So if a patient presents with a dizziness, I don't want to do a really, really thorough formal examination of that patient. I want to focus on specific things that I know are related to the time-sensitive conditions that I need to pick out in a dizzy patient. So I want to, in the general neurological examination, I want to focus on brainstem lesions, that's why I want to do a assessment of pain, and I want to check out if they have crossed lesions, like head on the left side or and leg and arm on the right side. And I want to, so your screening neurological examination, you emphasize on certain areas depending on what presentation symptom it is that the patient has, and then you do then you have on top of that you have your focused symptoms, which also is syndrome oriented. You don't do these tests on everyone, you do these on specific patients. So you do this, for instance, on the dizzy patients. If I have a acute vestibular syndrome with a nystagmus, then I'll do a Hintz test. And I'll do a Romber's test that I don't do with every patient, and I'll do several other tests. Also, I will be very cautious of looking at the eyes because I want to pick out the Horner syndrome. And in the same way, in a lot of the other presentations that we see in neurology, I want to pick out on top of my screening, which is my screening is quite focused depending on the presentation. Then I'll use some additional special tests that to hint out these syndromes that I want to find, and the time critical symptoms that I want to find. And we talked about the screening, and we might disagree with the neurological consult about what a screening consists of. And why do we disagree? Well, I might describe it like this. So we are interested in the time critical conditions. Sometimes maybe a few of the non-time critical conditions, because they might make it easier for us to rule out the time critical conditions. But in general, we are most concerned with the time critical conditions. So that's our filter. That's the filter that we go through, and that's why for instance, the SWESM screening, which I will show you, the SWESM neuro screening, which I will show you in a little bit, is quite narrow and don't have all the 6 points that I just told you that my screen has in the emergency department, because I was taught neurologically. And the neurologist screening may look more like my screening, as they want to know more about the non-time critical stuff, and they want to find the diagnosis, not just the time critical stuff. They are also interested in the time critical stuff, but they also want to find diagnosis, and that's not our purpose in emergency medicine, to find the diagnosis. This is the SWESM screen. They have picked out cranial nerves, motor, and coordination, because these are the ones that best present the time critical conditions. If you have a patient presenting with a cognitive problem, then that is one of the special tests that you want to do as well. But this is like the screen. This is the bare minimum that you need to do with a patient that isn't of any concern for a neurological problem, and then you will explode or apply one of the more focused tools in your quiver of neuro examinations afterwards. Notice also that the sensory has been left out, and I'll talk about the hierarchy of the reason why that is, and it's mainly because of the hierarchy of symptoms. Motor symptoms are objective, and they can be measured in a totally different way than sensory symptoms that are subjective and quite unspecific usually. So what I'm talking about here is the hierarchy of symptoms. The hierarchy of symptoms is such that if you have a sensory symptom that is high signal, meaning that the patient describes it in a very specific way, and it's a very peculiar way that would not otherwise present as a symptom. For instance, if you have a patient describing that they can't feel anything below their belly button, they feel like a tightening feeling in their stomach, like a belt, and it seems like they can't feel anything below their belly button. That's quite unusual. Usually we're not focused on our stomach in that way, and usually it's more like sensory symptoms usually occur in the arms or feet or something like that. But if they have very, very specific sensory symptoms like that, then it's a high signal symptom, and that's a high hierarchy symptom, I would say. But on the other hand, if you have like sensory symptoms that are coming and going and not specifically not like formed into a doesn't respect dermatomes borders, and then it's a like unspecific symptoms. You shouldn't ignore it, but it's really a low hierarchy. It wouldn't concern me too much if it's if there's no other context to it. So this kind of hierarchy where motor and language stuff is very high hierarchy, and others are lower hierarchy, is reflected in some stroke guidelines as well. This is a Canadian TIA guideline where fluctuating or persistent symptoms, including hemibody sensory changes, are a lower hierarchy for a stroke because they're more unspecific and they're harder to test. And where you have transient fluctuating or persistent unilateral weakness or speech disturbances, there are higher risk symptoms because there are more signal to noise. I would say they have a higher signal to noise. Usually, it's a strange thing to have weakness if you and you can test it in another way that you can't with at least sensory symptoms. It might be a bad example, but there is a hierarchy in the symptoms, and you don't have to test all of the things in your screening, especially sensory, as nuanced as you would some of the other symptoms. But if a patient presents with sensory disturbances, then I would, to a higher degree, go into the sensory. So it really depends on how the patient presents. But for the generic patient, undifferentiated patient, where I might have some kind of concern for neurology, I would not do a very thorough sensory screen because it usually leads me down a bad path. Okay, so spontaneous or versus formal neurological examination. So what do I mean by that? Well, this is talked about in Jane Fuller's book as well, and in other of the neuro books. And it's really important to know that we usually think of the examination as something where you have to touch the patient and where you have to make the patient stand up and do the leg weakness test and do the Rombergs and do the ataxia test and so on. Well, that's a formal test. And on the one hand, most patients a lot of patients can really comply with a formal test because they're older or delirious or so on. And also it's important to know that the spontaneous test is the patient doing their stuff as they usually do, and that is actually at least as informative. The spontaneous test is where you look from the bedroom door, or you look as you're walking with the patient and seeing that, well, they don't have a gait disturbance, or they don't have they are swinging their arms in the same way, both ways, when they are walking. But when I'm testing formally, they lose their arm. That's inconsistent, and that's why you have to. The spontaneous test I often use as my screening tool. Actually, look like doing a mental checklist for a lot of the motor skills and the sensory skill, not the sensory skills, but the coordination, and that might be enough for a lot of patients if you have especially if you have a low risk or low clinical suspicion of a neurological cause, for instance, in a syncope patient or something like that. In certain conditions, the spontaneous neurological examination might even be better than the formal. And if you think of your cranial palsy patient, then the traditional teaching is that you can discern the the peripheral from the central lesion by looking at the forehead, whether they can wrinkle or not, where the peripheral one cannot wrinkle their forehead and the central one can wrinkle their forehead. But if it's a very mild peripheral one, or if it's really early that they present, then it's usually not as developed, and they might be able to wrinkle their forehead, and you might not be able to discern the two just by looking at the formal test, asking them to wrinkle their forehead. But there's another sign which is really easy to pick out usually, and that is the spontaneous blinking. And this is something that you cannot usually test them with when you do. If you ask them to blink, not blink, blink, not blink, like formally, then you would they would not always be able to pick it out. But if you just, when you talk to the patient, when I have a patient with a facial palsy, I directly look at their eyes when we're speaking, and I can make the diagnosis right away by seeing that, well, you're not blinking as much with your right eye as you did with your left eye, meaning that you have a right-sided facial palsy. That is peripheral, or more rarely bulbar, but I will test for the rest of the neurological examination to check out that. Just as an example, that the spontaneous is really important, and I usually use that more so than the formal in most patients in the ED. Then there's this thing of, so when you have an ECG, it's important to look at the previous ECG. When you have a neurological patient, especially someone coming in acutely, where you want to do a stroke assessment for thrombolysis, then you want to know what was their previous neurological assessment like. And remember, I talked about recrudescence, that if their neurological assessment 2 years ago was with right arm weakness, and they now come in with right arm weakness that is worse than their baseline, then I want to check out, well, how bad was it 2 years ago? And if it's not worse than what it was 2 years ago, then it's maybe recrudescence. I actually at least have to think about that very carefully before thrombolizing the patient, and I want to discuss that with my neurologist. So that's really important to always compare with the previous examination, and that's also a thing that most emergency physicians might not do. But I like to, don't say in your assessment that, well, this is a peripheral facial palsy. I want to know, why do you think that it's a peripheral facial palsy? I want to see you that, well, diminished spontaneous eye blinking on the left eye. That's what I want to see. I don't want you to do a conclusion in your assessment, because if I want you to do that in your conclusion segment, but I don't want you to do that in your examination assessment, because if I don't know how good you are to assess a facial palsy, I don't know, you might miss the eye thing and see this as a palsy that is central, and then it might go back. And then now I'm a few years later here, or maybe a day or two later, I might be in the situation where I have to, well, consider, should I treat this patient as a TIA because you said this was a central lesion, and which I cannot examine anymore because now it's gone back. Now it's normal again. So it's important to describe what you see. Also, usually we don't know what we're talking. We don't know there's a lot of fancy words in neurology, and we might deceive ourselves if we just write the fancy word like no dysarthria or no dysphagia, and if we don't know what the definition of that is or what we're actually talking about. So I think if you're in doubt, always just write with normal words what you're actually seeing. That helps out much more. And then there's the yeah, the other point was because if everyone does that, then I'm able to get much more information when the patient rolls in the next day or the next year from the neurological assessment. So please write up your neurological assessment in words that is understandable, and you don't have to use the fancy words. And yeah. So principle number 6 here, and this is like a pre-brief on the next part of the lecture, because neuroanatomy, there are layers in neuroanatomy. So what turns a lot of people off neurology is maybe there's a culture when they got taught neurology that, oh, you need to know all of the small pieces of, and like the way this nerve runs through the brain, and you have pictures in your head of very, very detailed anatomical books on the wiring of the nervous system and so on. And I this has no use clinically, or it has some use if you are a neurologist and you have a specific problem that you can't make out. That's an encyclopedia. You need the key to understanding the neurosystem, and that is not looking at it like that. And I want you to know these keys, because I think that is like 95% of everything you're ever going to meet in neurology can be. I'll try to show you in this lecture. So I call this the bottomless pit of neuroanatomy, because there's always more you can know. You can always know more details, but usually you don't need it, neither in neurology nor in emergency medicine. So you have this bottomless pit, and you can always go further down. I feel like emergency physicians and neurologists should know this amount, and of course neurologists sometimes might want to know the details because they actually see these patients where you need to know these. But for emergency physician purposes, we don't need that. We don't need to know the diagnosis. We need to be able to make a decision on whether this is a time-sensitive condition that we need to do something about. So the basic level is this one. I'll show you later. Then you have your mental models, which is a bit more advanced, and then you have these hugely complex models which are not useful for us. It's hard to know when, because I have an interest and passion for this area, I might sometimes delve into areas that are a bit too detailed for the emergency physician, but I still think can be good to know. I'll show you this triangle when these times come, and then you know, well, this is not essential. Okay. I've talked about why the neurology priority and the emergency physician priority is different. We both want to know the time-sensitive conditions, but if it's not time-sensitive, then we are not as interested, but the neurologists want to find a diagnosis. So we have different interests in that, and that's usually the reason for some of our disagreements. Okay, so that was the first part of this lecture. And we've been through some fussy details about and pearls about neurology and neurology for the emergency physician that you might not know and might not have known about, and which I think are helpful to get the full picture. A lot of these things I've actually gone through in this probabilistic thinking and headache video, which can be found on my YouTube page and on akutmedicinen.dk. So it's really, if you're interested in this, please check that out, or please check the references that I've referenced throughout this lecture, part 1 here. I'll now go into the second part of my lecture, and this might be a good time to stop and pause, and otherwise follow me into this next part. Okay, neuroanatomy and the approach to the neurological patients in the ED apartment. So in the part 1, I talked about this approach, and we've delved into like something about the history taking, how we need to sit down, do open-ended questions, how the history taking is really important because of this triangle. It's really like most of your stuff in neurology and the undifferentiated patient presenting to the ED with neurological problems, you will do these things. This is not as important. It's important in selected areas, but you need to do the pretest assessment, and that is this. And to do a decent pretest assessment, you need to be good at picking out the details and knowing how to ask questions and sitting there and actively listening to the patients. Using Bayesian thinking, and that's something I've detailed in my other video, which I just linked. We'll now go into like this, what you have in the back of your mind, and part of what you have in your back of your mind is neuroanatomy, and that's what we're going to go through now. Okay. In neurology, we have what we might call where is the lesion, we have what is the lesion, and then we have these, what I usually call is there a lesion? And this is not traditionally taught, but that is my own thing that I usually want to, like, I use it as a forcing strategy, because otherwise I might forget to think about that the stroke patient might have a dissection instead of a stroke, or instead of a embolic stroke or other reasons for stroke. So this is it's like it's a de-biasing strategy or a forcing strategy. All of this I talked about in part 1 about the hardware, and now I have talked about all the mimics and all this, and here I will delve into the hardware. This is the nuts and bolts of neurology, and what kind of neuroanatomy you want to know about. So many people want, like, when you question the patient, some emergency physicians like the Socrates mnemonics, others like the OPQRS mnemonic, and I've just shown here that what kinds of letters belongs to what to which area of questioning. And actually, when you have a patient presenting with a neurological symptom, you can come very, very far by just knowing the basics of the nervous system and knowing what is the lesion. And what is the lesion is usually something about time. That's why I have a clock here. And where is the lesion has something to do with where like knowing the neuroanatomy somewhat, knowing the patterns. So where is the lesion is usually a position and the extra symptoms. And what is the lesion is usually onset, the quality of the symptom and the timing, because that will give you some information about what the lesion is. And what is the lesion is something about, well, is this a stroke? Is it a tumor? Is it a, well, all of these things. So that's, we'll go into it now. So what is the lesion? It's easiest to begin with. So if you have a, this is a map over the onset. If you have a patient coming in with like with vision loss, or with weakness in their arm, then if it presents hyperacutely over seconds, then we will usually think of it as being vascular or a seizure. Migraines can sometimes, but usually it takes a few seconds to develop, or minutes to develop really trauma, of course, and then you have some of the metabolic stuff, but usually it's vascular you want to think about when it's really within seconds. Otherwise, the subacutely are usually inflammation or infection presenting over weeks or days. And the chronic ones are usually more genetic or maybe incremental worsening over time, like dementia. There are parentheses here because the problem is that like something occurring hyperacute might be, I mean, you can lead your patient to say yes to your question. Did this come really acutely? And it's really important that you ask your questions right. Like you have to ask an open-ended question if there's time for it, because otherwise you might be leading your victim, so to speak, into the wrong pathway. Also, you want to be cautious because when describing the onset of symptoms, the patient might be describing that they just the patient just became aware of it, and that's something like vision loss is something that, well, in most situations you don't use your vision in that way, but then suddenly you come into a situation where you actually need your vision, and then they feel like their vision is lost acutely, but it isn't. It just became apparent to them suddenly. So there are some nuances here that is important to pick out. Also, with some of the tumors, sometimes they can present when some kind of critical point. When they get beyond some kind of critical point, when they suddenly have enough edema to create a seizure or have enough edema to create a symptom. And that might also present quite acutely, but usually through the history you can pick out that it's actually subacutely. But just to say that this is not set in stone, this is Bayesian, this is probabilistic. It's most likely if it's hyperacute, then it's vascular, but it does. But there are brackets around that. Yeah. Then there's the timing, which is important. If you have something that is, you might have these two patients, and the one patient describes it coming like, well, first it was the arm, then it was the leg, and then it was the other leg. And that is less concerning, especially if there's a long time between these. It might give us a hint about what kind of lesion it is, or, well, maybe it's not even a lesion, maybe it's not a lesion at all. But it's more concerning if everything comes at once, like everything came at once, all of this, even though I can't make it out what kind of pattern this is, what kind of lesion that might be. Then I'm more highly concerned for this being vascular if it comes right away, suddenly, all at once. Again, it depends on how you ask the questions. So the question asking is so important in neurology in specific, but in general in medicine. Okay, the quality of symptoms. Okay, so you might have what we call positive symptoms on the left here, and you might have something called negative symptoms on the right. And that's just a really broad way to deal to part the presentation symptoms of patients. So if you have someone presenting with a very with zigzags or with lights or any kind of positive symptom, like add-on symptoms, not like a gain of, it's not really a gain of function, but kind of a gain of function symptom, then you are more concerned with, well, it might be migraine, it might be seizures, it might be some kind of activity, it might even be stroke. It might be stroke sometimes, but it's less likely to be stroke. The negative symptoms, though, are more likely to be stroke symptoms, because it's something that gets destroyed in the brain. It's a part of the brain that doesn't work suddenly. So negative symptoms are more likely stroke, and positive symptoms are less likely stroke. But again, this is just one of your tests. This has a likelihood ratio that is unknown attached to it. So you have to look at the entire picture. So if you have someone with a positive symptom, but all of the other symptoms point at stroke, then I wouldn't say, oh, well, it was a positive symptom, I would not think of stroke. It just makes it a little less likely. Okay. So yeah, that's the Bayesian way of thinking, and that is the way that neurologists think about it, but they just don't usually say it out loud that it's a Bayesian thing. Okay, so let's try to these are the questions that you want to ask the patient for what is the lesion, to know what kind of lesion it might be, vascular or infectious or whatever, And let's try to do a case here. So you have two fagans normograms here, and you have a patient presenting with a monocular visual disturbance. So one eye, something wrong with the vision, but we don't know what it is yet. Okay, so what can we think of? Well, let's say this patient is 60 years old, then we get a couple of differential diagnoses. In emergency medicine, we want to have the time critical conditions at the top of our mind. At least, and we might think of 2 or 3 of those in each case of patients, and then we might have a lot of maybe more common conditions. That is, those are the like kind of rule out diagnoses. And then we have more uncommon both time critical and non-time critical conditions that we might think of in this particular case. So let's try to. I would say if I have this presentation, monocular visual disturbance in a 60-year-old, I will think that, well, monocular, for reasons I will tell you about later, are usually ophthalmological until proven otherwise. But when they present it in my emergency department, I need to think about the time critical stuff. And the time critical stuff for me not to miss would be an amaurosis fugax, a TIA, or a GCA, giant cell arteritis, or temporal arteritis. So I will. So these are on the top of my mind when there's visual disturbances. The palsies, well, I mean, we need to know what kind of disturbance it is. Maybe it's double vision, then I would think palsies much more than the other ones, at least. But we will have to get more information. So let's try to get a bit more information. And let's say, well, without knowing anything else, 60-year-old with monocular visual loss, I will set the pretest probability to maybe 10% for amaurosis fugax because it's a really common condition. And the GCA, it's quite uncommon, but the patient is over 60, but usually they're only over 70 or even 80. So yeah, let's just arbitrarily set it here at like around 3 or 5%. Okay. Let's get more information then. We get the information that it's sudden. When it's sudden, then suddenly the TIA gets up a bit because in pretest probability, because, well, it's sudden, and that tells me it might be vascular. And usually giant cell arteritis does not present with sudden onset. Then there's the quality of the symptom, and they say that this was not diplopia. This was loss of vision. Well, that fits really well with my TIA. It increases even more, and it was painless, so that fits even more with my TIA. It does. Like loss of vision is it is true for temporal arteritis as well, and it was painless, which is also fitting with temporal arteritis. But it's because it's so uncommon temporal arteritis, and we don't have anything else. Then I'm not that convinced yet about that kind of diagnosis. Let's go on. Then we move to timing, and then the patient says, well, it got gradually worse and worse over minutes. So it came on sudden, but it worsened over minutes. That's kind of strange that's not classical for an amaurosis fugax. It doesn't really lower it doesn't really lower my concern that much, but it really doesn't increase my concern. But because there is so much else going for the amaurosis fugax and in the context of all this, I mean, the patient might just be describing this in a strange way, or I don't know. I would say that in my TIA kind of diagnosis pathway, that would be maybe noise. But here, this might be more concerning for this, because that's usually gradual over. Usually it's gradual over more than just minutes, but it might be a bit more here. So now we have both of them are quite likely. And we really want to get some questions in that might like discern the two, so we can tell them apart. Then the patient says that, well, it became better after 30 minutes. Okay, well, that's quite classical amaurosis fugax, and less classic temporal arteritis. So that went down again, and the TIA went up a bit. And then, like the last one, we get the blood samples. This is one of the cases where I wanted blood samples, because I do want to know whether the sedimentation rate of the thrombocytes or the CRP, how they are. And they were normal in this case. So my concern for giant cell arteritis, temporal arteritis, is lower. I just wanted to say about the last slide that going through a case like that is not how I do it in real life, but it's just to illustrate that each puzzle, each part of information attained is important, and how we attained it is important. I didn't go into that in this case, but we just assumed that the data that we got was good. What I want to say is that this is when we've been in talking with the patient, then afterwards we might like think about this, like what kind of diagnosis was the biggest, what was the weaknesses of that hypothesis, what was the strength of that hypothesis, and that's what like gets our pretest probability up and down, as I showed. But I don't do it in real time with a fagans nomogram with every question like that, but just to illustrate how my mind works and how the Bayesian mind usually works, and in these kind of cases after you've been in talking with the patient. I'll move on now to the concept of where is the lesion, and this is Neuroland 101. This is what neurologists needs to know. This is neuroanatomy and practical neuroanatomy. And as I said, I will go through this in a way so that after going through this series of slides and this lecture, you will be able to treat, I would say, 90 or 95% of your patients in the ED. Okay, and I just wanted to remind you of the bottomless pit of neuroanatomy. I'll go through the big part here first, the basic part, and it's the most important part that you need to know. So if you don't know all the fancy mental models that I'll show you later on, that's okay. This is what you actually need. So that's the bare minimum, and it's not just bare minimum, it's really, really the most essential thing. So if you only know that, great. So let's go into it. This is the entire nervous system. You have a brain, you have your brainstem, you have a medulla, and you have nerves going out from the medulla all the way through, but here represented with just one nerve. And you have a muscular nerve junction, and then you have a muscle. This is the nervous system. And you do also have your autonomic nervous system, which is not illustrated here. And you have your enteric nervous system, but this is like the nervous system that usually presents to the ED and what you actually need to know about. I told you about the 1-to-1 ratio, like the hardware problems where there's a lesion one place in the system, and we need it will present in a specific way, and these specific ways that it presents is something that we will illustrate with these patients. These are the mental models that you need to have in your head, keep in your head, and if you know these mental models when they present, then you know where the lesions are. So let's go through it. As a generic basic level, the if you have a lesion in your brain, then oh, sorry, I put two keys here because it's so important, this slide. If you have a lesion in your brain, then you will have contralateral problems, right? There are details to this model, but in general, as a rule of thumb, basic rule of thumb, contralateral lesions. So if you have a left-sided lesion, you will have right-sided symptoms. Moving down to the brainstem, if you have a brainstem lesion, you will have what we call crossed over symptoms. So you will have, if you have a lesion on your right side here, then you will have a ipsilateral, meaning on the same side, cranial nerve deficit, and that might be different deficits depending on where it is, and you'll have a contralateral deficit on the left side here, and that might also be either motor or sensory. The color of this just signifies lesion. A deficit. It might be motor, it might be sensory. Okay. Moving on to the medulla, and the medulla can be quite hard, and there are a large part of variations in the medulla and how they present when there is a lesion there. But in general, they will present with a paraparesis, para meaning on both sides. So they will have a paraparesis or parasensory deficit. So if you have both limbs, either both arms, both legs, or both arms and legs, but no cranial nerves, well, no lesions, no symptoms above the neck, you will think of a medullary lesion. Okay. Moving on to your peripheral nerve, and here you will usually present with distal deficits, either motor or sensory, or both. And there are also a lot of variations here, but this is the general picture. And if it's severe, it will even be in the stomach region, because the nerves wrap around, come from the back and wrap around and go into your stomach, go out to the stomach, and the same on the left side. So the distal parts of the nerves, which is also the hands and the feet, is also the middle of the stomach. So that's why you might, in severe cases, see that in nerve problems, neuropathies. Okay. Then you have your muscular junction and your muscle, and here you will present with a proximal weakness, and these cases are usually only muscle. It's only weakness. It's usually not sensory. The patient might describe some kind of sensory vagueness, but it's not really. It's not a deficit. It's usually just something else. But usually it's classically only motor symptoms. Yeah. Okay. So this is the mind map that I want you to think of when I say where is the lesion. I want you to be able to bring up this and take a mental picture of this. Okay. Another version of this you might find has a bit more detail on whether it's a root or a polyneuropathy, but in general I don't care about that much. Either way, which picture you remember is good with me. It's the mental models I want you to remember. Okay, there's one more mental model in the basic level here I really want you to hammer home. That is this one. Wait a minute, it's the same one. No, well, I'll draw a line. There is a line here, and the line signifies the difference between central nervous system here and also going down here. Sorry, the line didn't work that way, but it's medulla and the brain and the brainstem. That's the central nervous system, and you have your peripheral nervous system, which is your nerve and your muscle nerve junction and muscle. Okay, so this is really important in a lot of patients because if you get a lesion in these places, there are there are findings that signifies which area it is, which we call the lower motor neuron syndrome and the upper motor neuron syndrome. And the reason for those names is because, well, I guess there's only one neuron going all the way from the brain down to here, and then it's connecting with a lower motor neuron here. There are some details, and it's not always just two neurons, but that doesn't matter. You have a lower motor neuron and you have upper motor neuron syndrome, and depending on which one is affected, you will have different findings on your examination, and that's important. The different findings is usually is what you will find here. So lower motor neuron syndrome will have a flaccid paresis, where the upper motor neuron syndrome will have a spastic, meaning that if you test for tone, you will have a catch. You will have a catch phenomenon. They will be hypertonic. They will have a high tone. You might even in certain patients have cogwheel if you have Parkinson's, but they will have a spastic tone, and they will have a flaccid if it's a lower motor neuron syndrome, a nerve lesion or something like that, or a Guillain-Barré. Okay, then you have your reflexes, and here you will have low reflexes or no reflexes, and here you will have a hyperreflex. There is a small thing here. Hyperreflexia is so you can have very lively reflexes, meaning that they are more lively than the ones that don't have any or hard to find reflexes on. Both of these categories can be normal. You always test with the other side, like if you and see if there is any difference. But sometimes patients have lesions where both sides are affected. And there you want to know about, do they have extended zone of reflexes? Like if I test the Babinski, if I test the patella reflex, do they like? Is that elicited? Also, if I hammer with my reflex hammer all the way down the shin, well, that's a pathological reflex because it is elicited even when I'm hitting the shin as well. In the same way, you can find these in different areas of the body. Again, this is only one sign. Some people out there do have very, very lively reflexes and have so lively reflexes that they would be in that above 95% Bell's curve, and they might be more normal anyway. So it really always depends. It depends on the context again. Then you have your Babinski's phenomena, and your Babinski's phenomena is you also have a so the Babinski's phenomena would be as a child you have this Babinski phenomenon where if you stroke the sole of your foot from heel to toe, you will and it's highly debated whether it should be a sharp or a dull object. But anyway, if you do that, then you will be able to see a reaction where your big toe goes up, and maybe even the entire foot. This goes away in a couple of months when you grow from childhood, and then it might come back if you have a central lesion. And that is not something that you will find if you have a lower motor neuron lesion. The thing about the Babinski's though is that it's really a lot of people are really ticklish, and I would not. You have variations of doing this plantar reflex, and that would be doing what's called the Shattuck reflex, where you use the lateral side of the foot to elicit it. And there are another one, I can't remember the name, but where you do the shin where you drive your the shaft of your reflex hammer on the shin to elicit it. So there are different. If your patient is really ticklish, or they have really hard soles on their feet, then or hard skin on their feet, then you might do a different one. And then for the last one here is that you will over time see muscle atrophy and fasciculations, meaning small muscle twitches. And we can all get muscle twitches, especially in the eye region or other places, especially when we're stressed or for other reasons. That's not pathological in and of itself. All of this has to be seen in context. I want to stress in this picture that the problem in emergency medicine is that these features of upper motor neuron syndrome, they usually first develop over a few hours or even or days. So if you have a patient coming in with stroke, they will not have these features. So you cannot use it in the patient who has only had symptoms for a few minutes to hours. It develops later than that. But no rules without exception. If you have someone who has had a epileptic seizure, they will usually have a positive Babinski if it has been a complex or a general seizure. Okay. But this is important when we have, especially when we think about the Guillain-Barré syndrome. This is really important because this is how patients with Guillain-Barré might look like someone who might suffer from something central, but they have all of these, or at least they have the flaccid, and they have especially the hyperreflexia or areflexia. So that's really important for the emergency physician to know this picture. Okay. An important point here is that these presentations are not set in stone. I'm telling you that, well, if you have a hand lesion, then if your patient looks like this and it has a lesion right there, then it must be a peripheral lesion. That is not the case. It really depends again on the presentation. It's just the most likely, but I can equally make arguments that it might be a central lesion. So I'll go through a couple of cases through this lecture to try to show you that you can always argue that a lesion can come from a central place. But it's just less likely usually. Let's try to have this patient there. You have this patient that I just showed you has a sudden atraumatic thumb weakness. Okay, just the thumb. And we have our nervous system here. Where is the lesion? Well, we might think that the most likely area, and usually the only area that we're thinking of, would be, well, he had some kind of carpal tunnel syndrome or some kind of peripheral nerve lesion. It's only the thumb. It's atraumatic, which is kind of strange, but I mean, carpal tunnel syndrome or other kind of neuropathies are common, so that's the most likely. Okay, so, but I will argue. This is just taking that point home, that there is some likelihood that there might be a central lesion for this. There's also I could also argue that this might be a muscle problem, or this might be a medullary problem, or it might be what we call there is no lesion, or what I call there is no lesion. It might be a software problem as well, or a medical problem, a mimic. Okay, so if we take this graph, which is a Bayesian graph, like if we plot all of these things, and I usually call this the Bayesian landscape, because assuming that the patient only has one diagnosis for his concerns, the sum of all of these are 100%. So this is 100. And if you add up all of these columns, then it would be 100%. All your differential diagnoses would be 100% when you add them up. So what is the risk? How likely is it that this maybe as a lesion in? Sorry, I made an error here. This star should be green and this star should be yellow. So how likely is it that this peripheral lesion, this thumb weakness, is a peripheral lesion? Well, it's, as I said, it's really common. It's likely. So that is the most likely. I don't know exactly how likely it is, but that is the most likely before examining our patient. But the other one, well, somewhat serious. We want to know the time critical thing here. So the lesion in the brain would be a time critical thing that I want to think about, right? So how likely is this? And it's not as likely as the peripheral lesion. It's quite uncommon to have what we call a homunculus stroke, a stroke in only one particular big area of the homunculus. But it's not totally unlikely, and it's really serious if I miss it. So I want to be able to know that. Then there's this concern of, is this medical or even functional neurological? Well, medical maybe if it's an emboli. Sometimes I cannot think of other things right now that might be the cause of this. So I mean, yeah. And then the other one, like, is the lesion somewhere else in the brain, or the brain in somewhere else in the nervous system? It's quite unlikely. So these are actually the two of most concern for me. So how do I go about doing my test? So this is our pre-test landscape of differential diagnoses here. And I want you to give me 3 questions or exams that you want to do next, and also consider how you would go about asking these questions. Would you do it specifically or openly, or how would you ask this patient the questions? Okay, so let's go on here, and I'll show you my answers for these. And we can argue about these, but I think some of the questions that are important to use are these, and exam findings are these. I want to know, for the exam, I want to know the movement of the thumb and the rest of the hand. And the reason why I want to know the movement of the thumb is that I suspect that if it's a peripheral lesion, there will be a very distinct pattern of lesions. Like if some movements are okay and other movements are not okay. From the anatomy of the median nerve. But if it's a homunculus stroke, I would think that then there would be it's the entire thumb that cannot move. So that's important to me. That's why I want to know the movements of the thumb. I also want to know the rest of the hand, because I mean, you could have an emboli in just the small artery going out to the thumb, but that's highly unlikely. It's more likely that you might have it for the entire hand. So that's why I want to test the entire hand as well. And that goes through. And in general, then I want to know, are there any risks of low flow for the emboli, and is there a history of painful? We know there's no trauma, but is it painful also here? We might think of this. These are just 3 questions, and in emergency medicine we often, I mean, there's an unlimited amount of questions you can ask, and an unlimited amount of exam findings that you might find, and so on. And it can be, this is a good test also of doing what we call a forcing strategy. Just think 3 questions, because then you will frame your mind and you will focus on what is most important usually. It's just to show you that it's a good trick to say, well, give me 3 exams or 3 tests or 3 history points that you want to do, and how would that change your probability? Okay. So here the answers are: the hand is okay. There's no movement problems there, but the thumb has no directions. Okay. It cannot move in any directions, not up, down, not abduct or adduct. It cannot flex or extend. Okay, but it has a good. There's no. The sensation is all right. Okay, he has no risk factors, no pain, no trauma. Okay, so again, this is a very staccato way of going through a case. It's not how I would usually do it, but these are tools to get you to become a better clinician in emergency medicine and also in neurology in this specific case, because these will help you get better at thinking about thinking and how you decide. Okay, so how would our probabilities change from this? Well, I would say like this. So the metabolic, the embolic one would go down. There are no risk factors for it. The hand is okay, so it's a really small area, and why should there be an emboli right there? I mean, and even if there is, can I do anything specifically about it? If it's a thumb, well, maybe because it's a thumb, but I would say that the risk is really, really low for this, and we are below some kind of treatment threshold as well. So then I will. The lesion in the brain is more likely because of it doesn't move in any directions. It doesn't move in any directions at all. So that is highly suspicious for this. And then this one goes very much down, because I would suspect. I mean, you could have. If you have a lesion, peripheral nerve, then you have even in the hand. You either have your median, your radial, or your ulnar nerve. And if you have a lesion there, then you usually have, well, you will have sensory deficit. You will have other deficits, like it's not only the thumb. You will usually have also some of the other fingers. So you might explain that there is no movements in the thumb just by saying like, well, all nerves are damaged. Yes, well, but then I would suspect other fingers also to be weak, and they're not. And I would also suspect there to be sensory deficit. So this goes down, way down. And well, the other lesions, I don't get any real information about those. So I'm really concerned now for a brain lesion, a homunculus stroke, even though it came in with a weak thumb. So this is the post-test probability after my assessment. And after this assessment, I will now, I mean, what I haven't done here is I haven't shown you what I would call the diagnostic threshold, the threshold for doing a test, where on the lower side of a diagnostic threshold, it's more harm to do the test than it's benefit for the patient, and on the upper side, it's more benefit than harm to do the test. And likewise, I haven't done the treatment threshold for the conditions. My treatment threshold for this, like at which threshold would be beneficial to treat, and these thresholds are different for different reasons. And if you want to know more about that, you should look up Kashira's threshold model, and also check out my blogs on the threshold model. But let's say like the homunculus stroke, the diagnostic threshold will be quite low because it's a really serious condition. I have a good test to check it out, and I can just admit the patient and do an MRI later on. So I have good tests for this. I have a system, and I have it's a really serious condition that I want to know about. And my treatment threshold though is quite high. I don't want to thrombolize this patient, but there are different treatment thresholds that I do want to do. I do want to load my patient with ASA, with aspirin, and then my threshold for that is really low. It's even sometimes as low as my diagnostic threshold, because if you don't know, you might as well just admit your patient, do a CT, and then load them afterwards, and then make the neurologist look at them tomorrow or do an MRI tomorrow to make a more definitive diagnosis. Okay. Likewise, you can plot in thresholds for these. The reason why I've even considered emboli is because it's so serious if I miss it. So therefore, I have a really low diagnostic workup threshold for that. But it might be here, and that's why I'm not working up this, because even though I haven't ruled it out entirely, it's really really hard to rule it out entirely without CT of the hand with a contrast, and I'm not going to do that. And notice also that when this one moves up, the other ones goes down. Like that's why it's, the summation of all of these are 100%. So when this one goes up, this one goes down, and this one goes down as well. And that's part of the reason why also we want to know about some of the benign conditions. Like if you have someone with dizziness, and dizziness can be extremely hard to diagnose or to discern. I'll not go into details with dizziness in this lecture, but I just wanted to pin this point home. So if you have someone who's dizzy and you're not sure, but you do a Dix Hallpike on them, and they have a really obvious Dix Hallpike positive, then it's then the likelihood of this being a BPPV goes up really high, and then the risk for the other ones goes really much a lot down. The other differential diagnoses. So therefore, it might be important to know some of the benign conditions and how to discern them from a time critical standpoint, because it does help you a bit ruling out some of the conditions. Okay, let's move on. This now we've done like the basics here, and again, these are really important basics. If you only know that, that's incredibly important, and you can come like 80% of the way. The mental models I will show you are maybe the last 10% or maybe 25%. I don't know, but these are what comes next here, and these I want to show you the keys to these things, right? These are like, think of these like small keys, small mental images that you want to have in your head. This is not a thorough neuroanatomical lecture on these. I want to show you the big things, the keys. Okay. So it's kind of like I said, there are nuances to all of these, and that's what I want to go through. Each of these each of these presentations, I want to go on the loop and show you some of the nuances in these presentations. First of all, we'll talk about the brain and the brainstem. So we know this is the most basic presentation. There are something above the brainstem where you have the contralateral lesion, and you have something on the brainstem level where you have your crossed lesions. Okay, let's go through the above the brainstem. This is, and here we have the marker. This is maybe moving into too much detail, but this is the vasculature of the brain here. And you have your heart down here, and you have your aorta, and you have then the arteries going up here, becoming the carotid, internal carotid artery, and then you have your vertebral arteries here. So this is the classical thing we usually see, but I like this picture because we have the entire circulature here. You can also see why a dissection might go up and dissect all the way to a media infarct, or and you can also see the color scheme here is made in such a way that you can see which area of the brain are hit. And this is, I mean, this is important this is what stroke neurologists know everything about, because, well, yes, the rule of thumb is that the contralateral side is hit, but there are different syndromes depending on what area of the brain is hit, right? So if you have this side, then if you have a anterior lesion, you might have an arm and a facial lesion. If you have a posterior, you might have a different kind of syndrome. So you have different syndromes depending on what area of the brain, and that is a more nuanced way of making it more or less likely that this patient has a stroke. So it's important to know these things as well. But it's a level, it's a higher level skill. And you can always go into more details about these. One thing I wanted to mention is that you do have some areas in here, like the thalamic stroke, that can be highly, what do we call it? They're really, really hard to tease out sometimes, because they might have waxing and waning symptoms coming back and forth, and they might even present with pain, like a painful symptom in the unilateral side of your arm, or yeah. But these are rare. But that's also an expert tip. Okay. Moving further along with the brain, we have we can deal it into cortical and subcortical. Okay, so this is a section of the brain where you have your homunculus, you have your axons going down here into one point, and the capsula interna, internal capsule between the putamen and the thalamus. You don't need to know all of these, but the capsula interna, the internal capsule, is an important area, because this is where all of these collect, and it's clinically important, as I'll tell you next. And then they go down to the brainstem. Okay. I wanted to, we call these cortical lesions and we call these subcortical lesions, and they present in different ways. So you have 3 points I want to make here. You have your homunculus area, which, if you have a really, really peripheral stroke, then you will have a stroke that might only affect the thumb or the foot, because these are really huge areas, right? But it's not like the little finger. That's too small an area probably to actually get a homunculus stroke. But the bigger areas where the homunculus is really big, that would be like the thumb or the foot. And you might see entire units like that being weak in all movements, and that is highly concerning for a homunculus stroke. The other point I want to make is that the difference between the cortical and the subcortical. So if you have a cortical stroke, you will have neurological deficits, weakness, or vision, or otherwise sensory. But you will also usually have cortical symptoms, and these might be hard to tease out sometimes. But like the main ones are, like, you might have, if you have a right-sided brain lesion, you will have neglect, visual spatial problems, and if you have a left-sided, you might have language problems. This is like the very wide, but there's huge nuances to the cortical problems. And if you have a frontal lesion, you might have perseverance, like you do everything more than once, or you do everything a lot, or you out of proportion to what I'm asking you. But these are cortical symptoms, like neuropsychological symptoms, like these are higher function symptoms. But if you have a subcortical lesion, not talking about thalamus here and not talking about these, but if you have a capsula interna lesion, then usually you will have, because all of these strains, axons, they collect in one point here. You can just one small stroke might give you a lot of lesions, right? You might be left with arm weakness and arm paralysis and arm and leg paralysis, depending on where in the capsula interna. But a quite small minor stroke actually. But you won't have any cortical symptoms. A last point I want to make is that we all know about post-apoplectic epilepsy. After a stroke, you might get epilepsy, and these are usually, the more cortical they are, the higher risk. Like especially the ones all the way out here, they are a higher risk than the ones deeper down. That is usually the teaching anyway. Okay, then we have the cortical symptoms, and I just want to show you left versus right. And we already talked about this, but the left-sided symptoms, this depends on your dominance, whether you are right or left-handed, or left or right dominant. But in general, it's like 95% of left-handeds that are that have the speech sensor in the left anyway. So assume that all patients have the speech sensor in the left hemisphere. That would be the best, I think. But I want to stress this, that there is difference between dysphagia and dysarthria. Dysphagia is a higher cognitive function where you have your Broca's and your Wernicke's area, and this information goes into the motor area, and then it goes down. So everything before the motor area, that would be dysphagia, and everything after the motor area, going from here and down here and moving all the way out to the muscle, that is dysarthria. And it's important to when often when we have a code stroke, then the personnel from the ambulance will sometimes say, well, this patient has dysphagia, and I will again say, well, I'll just back up. Well, the patient has language problems. Why do you think they have dysphagia and not dysarthria? And then I want them to explain this, because we are in risk of being framed here, of having and also what we call diagnostic momentum, that they have already made the diagnosis, and it's hard to stop and say, well, what's that actually? Let's just pause here and what are your arguments for this? And there's a balance, because you have to rely on your colleagues, but you also have to be skeptical of the data that you're getting, especially early on, because that might lead you in the wrong direction. The early data is so important. So I just wanted to stress that. Dysarthria is motor, and dysphagia is the cognitive or higher function. And you might part the dysarthria into spastic, meaning like talking like you're talking like you have a potato. That's kind of how they speak. And the flaccid would be more like, it's really peripheral. It's like they are like usually facial palsies will usually have a flaccid dysarthria. You have other more special dysarthrias like cerebellar dysarthria, but you usually don't see that without MS or other more rare diseases, so I won't go into that. Okay, the flaccid dysarthria is something that we are very aware of in the emergency department, because if you have any kind of sedative, you have intoxicated patients, alcoholics, stuff like that, then usually they will have a flaccid dysarthria as well. So dysarthria doesn't necessarily mean that they have a stroke, but this central spastic dysarthria is something that is concerning for a central lesion. Dysphagia can be teased out by 3 questions. It's follow my command, and you're not allowed to show what kind of, like, look at the ceiling, and you're not allowed to point towards the ceiling, or just only have to. There you're testing the impressive part of the speech, and if they can speak fluently, you have a conversation with them. If they can speak fluently without stammering or without stopping, then it's probably not a broadcast problem either. And then the last question is, can they repeat your questions? And that's kind of a rare kind of conductive dysphagia. But usually they are mixed, these two. And the reason why I'm going into details about this is that when you assess language problems, it's really good to know, do you think it's dysphagia? Do you think it's dysarthria? Because this is a thing that we get a lot in my ED, and it's usually done wrong. So, okay. Then you have your right-sided problems, which will your right-sided cortical problems, like and like they might give you neglect, visuospatial problems, where you underappreciate the left side, and then anosognosia. It's important to know that this is an underappreciation. It's not, I mean, when they come in with a big stroke, then it seems like they can't see anything on the left side, and it's hard to discern from visual disturbances sometimes. But if it's more subtle, then usually they can appreciate their left side, but they just favor the right sides, sort of. So if you test them, you will have to test them first, like, can you feel the right leg? Yes. Can you feel the left leg? Yes. They will say yes to both of them. So you have to bimanually at the same time touch their legs and say, which leg am I touching? And then they will usually, if they have neglect, then they will say, well, you're touching the right. They will favor the right when they are bimanually touched. And the same thing goes for your eye vision when you're doing your peripheral vision test. So that's visuospatial neglect and sensorineural neglect. Then you have your asognosia. Like, it's a word meaning that you're not aware of your symptom. There's this really strange syndrome in neuro where you have, it's called Anton's syndrome, where you have a lesion in both of your vision areas in the back of the brain. And but Anton's syndrome is that you are not aware of it. So you persevere. You say that I can see, even though you clearly cannot see anything. That's Anton's syndrome, and that's the thing about this. It's being uncritical or unaware of your symptoms. That's anosognosia. And patients with a right-sided lesion are usually really uncritical. They will usually try to, sometimes if they have a real big lesion, they will usually try to leave the hospital or say, I want to leave because I'm all right, even though they have a massive left-sided paresis and they can't walk. Right. Okay. So that was the left and right hemisphere. Left-sided speak and right-sided is neglect usually. There are much more nuance to this, and that's how you become a neurologist if you go into that. But this is like at the level of what I would suspect us emergency physicians to know. Then you have your episodes, and there's one mental picture I want to tell you about, like loss of consciousness and transient loss of consciousness, because oftentimes I have a patient having a syncopal episode or a transient loss of consciousness, and the question sometimes is that, well, could this be a stroke? Well, I'll show, or you have a patient with a what you think is a seizure, and they're moving both arms and legs, but they're also like talking and they're looking at you. So I want to show you this mental model to show you why this is not logical thinking. Okay, so your awareness depends on two things. Either it's the brain, or it's what you call the Aras the Aras area in the brainstem. For you to be unconscious, you will either have to put out both light bulbs, not just one, both of them, or you will have to put out the battery to the light bulbs, which is the Aras system. How can this happen? Well, if you get a stroke in one area, then you will have a light bulb missing here. But you should be aware. If you're not aware, then you either have a seizure making this way all over the place, making both light bulbs go out, or you will have a seizure, or you have maybe what you would call a malignant media infarction, which only develops after days usually, where you have so much edema that it presses on the other one. So or you might have a top of the basilar syndrome where you have one stroke here. In either way, these stroke symptoms, syndromes where you become unconscious, are, well, first of all, something that you don't get up from. If you lie on the floor and you get up right away, then it's not a stroke. There are very, very, very rare exceptions to this rule, but in general, that is the case. Can it be a TIA? I mean, you do have something called stuttering strokes, and if you have a stuttering stroke that goes on and off in the back of your arrest system, then maybe. But I mean, I think this is a casuistic level kind of thing. In general, the rule of thumb is if you go down and you come up again within a few minutes, then it's not a stroke. Okay. The other thing which I often hear is that how do I discern a dissociative seizure from a real seizure? Well, one of the main points is if you're moving both your both sides of your arms. Remember, this area steers the contralateral side, and this area steers that contralateral side. So seizure here would make that arm move. Seizure here would make that arm move. If both lamp bulbs are out, meaning that if you have seizure in both arms, then both lamp bulbs should be out. You should be unaware. You should be unconscious. So if I can take the hand of my patient who seems to be seizing, and I can talk calmly to them and say, it's all right, don't worry, and I can catch their eyes and they can catch mine, then I'm quite sure that it's not a seizure, but it's more likely to be a dissociative seizure. That's just one of the small points on how to discern, one of the main points, how to discern a seizure from a dissociative seizure. Yeah. So just to hammer home, a stroke patient with loss of consciousness is not transient. And if you have this kind of seizure thing, it's always, I mean, I would not hang my hat only on them meeting my eyes. There are some rare frontal lobe seizures that can do weird motor things as well. They are rare, and they should be stereotypical, as I told you. But I don't know. I don't always know that when I'm standing with my patient. So there are other features of a apparent seizure that may push you in the way of this being a dissociative one. But some of them are tongue bites, are usually lateral. You usually have muscle acheness, but lactate. I mean, these are really low likelihood ratio, but small puzzle pieces. Like you might have lactate, but and seizures usually only last 1 or 2 minutes. Seizures that goes up in frequency and then go down and then go up again, that's highly unusual. So that there are a few things that can tease out whether this is a real epileptic seizure or not. Remember, even though it's not a real epileptic seizure, they're usually not faking. This is dissociative, it's subconscious. So as I told you in part 1, be mindful of how you communicate when you tell them what you think the diagnosis is and how you work them up. Yeah, this is just to say, look into their eyes, try to catch them, because that is a conscious thing to do. And if you can do that, usually by also saying it's all right and stroking them and saying their name and so on, then usually you can catch their eyes even though they're kind of ceasing. Okay. In general, when you have your patient with a loss of consciousness or a transient loss of consciousness, you want to think of your history in 3 parts, like your pre-ictal, your ictal, and your post-ictal, meaning before the seizure or before the episode, even the syncope as well, under the episode, and after the episode. And through this kind of history taking, you can discern whether this is a syncope or it's a more neurogenic one. The cardiogenic syncope would usually be without any kind of preictal symptoms, without any prodrome. It might have chest pain, but that's highly concerning if it does. And then you have your ictus, and it's for cardiogenic reasons usually very, very short. And then you get up, and it's really fast that you get up. You have a fast recovery with that. On the other hand, if you have a seizure, epileptic seizure, then usually you might have a prodrome. You don't always have it, and that's why it's sometimes hard to discern whether it's epileptic or it's cardiogenic. Your ictal period is usually 1 minute or 2, as I said. They're usually self-limiting. If you don't limit yourself within 5 minutes, then it's a pragmatic definition of status epilepticus. And then you have your post-ictal. And your post-ictal, depending on what kind of seizure you have, you might be what we usually call post-ictal confusion, right? So, and then you might be Babinski positive, you might have lateral tongue bites, and so on and so forth. So that's sometimes you need this information from a proxy, meaning that you have to call the patient, to the person who saw it, and it's really important to write that down in detail, eyes open, eyes closed, which side was the seizing on, so on and so forth. That's the semiological description of the episode. What I also want to tell you about is there are what I also wanted to talk about is a syncopal episode is usually the reason why it's a syncopal episode is that when you don't get blood to the RAS system or the two hemispheres, you will pass out, but it's transient because when you lie down, you will get that back because hemodynamics will be restored. The thing is, though, that you can have movements, what we call post-syncopal myoclonus or post-syncopal movements. And there's a great video on YouTube about this, where they get volunteers to pass out by squatting down after hyperventilating. And you will see that these apparent seizures, which aren't seizures, but these post-syncopal movements, they to the untrained eye look like seizures. So it's really important to actually know about this, and to see this video and see the variation of a presentation with these post-syncopal episodes. Yeah, and here's the link to that video that I told about the post-syncopal convulsions or seizure-like movements. Okay, that was all about the above brainstem, the brain kind of thing. We will now go to the brainstem just shortly, because I feel like most of what you need to know is actually that they have crossover symptoms. You don't need to know the details. If you really want to know the details, Life in the Fast Lane has done this blog about the rule of 4. I've done a lecture on it as well. Please comment if you want me to post this lecture as well. Then I'll do a podcast on it as well. And in quick summary, it's like this. If this is a brainstem, you have something called the 4 M's, and you have something called the 4 S's. I won't go into details what they actually are. You have to look up the Life in the Fast Lane yourself, but and that is the rule of 4. But in general, you have 2 syndromes in the brainstem. You have the medial brainstem syndrome, which is usually quite obvious because they have motor symptoms. That's one of the 4 M's. But then you have your lateral unilateral brainstem syndrome, which is usually hard to catch, especially the most common one called the Wallenberg's syndrome. And that's because these S's is like, it's sensory. I can't remember all of them in my head, but it's like sensory, and it's spinal cerebral, and it's also the sympathetic nervous system. So these patients will usually present with they might present with dizziness, and these are usually the syndromes with acute vestibular syndrome that we want to pick out for being of concern of central lesion. These are usually it might be cerebellar, but it might also be these brainstem syndromes. Another key factor of this is like the Horner syndrome. These patients will have a Horner syndrome, oftentimes anyway. So that's like the medial and the lateral. Another key feature of the rule of 4 is that it's parted into the brainstem can be parted into 3 groups, where it's the pons, the mesencephalon, and the medulla oblongata. And the brainstem is such a narrow tube, right? A lot of stuff, like all of the stuff, goes through here. But so there's not a lot of space. So if you have someone with a maybe, oh, I can't feel my face. Okay, could that be central? Could that be a stroke? Well, I mean, you would have to, if you can have a isolated facial trigeminal nerve lesion in a central, right? You can have that, but it's such a crammed space that you would touch some of the other nuclei in the brainstem, the other cranial nerve nuclei, and the cranial nerve nuclei are dealt into like 4. So like there are 4 up here, there are 4 here, and there are 4 here. So if you have a problem with your and the middle one is the hardest because the number 5 goes actually all the way through, and the number 7 goes all the way through. So there are nuances to this, but in general, I had a patient who had a glossopharyngeal problem, and then I'm coming in with fever and progressive symptoms, and he couldn't swallow. And then if you can't swallow, that might be just a stroke. A lot of patients have a central, like a stroke in their hemispheres, and that will make them get dysphagia. That's quite common, and it's, I don't know, maybe above 50%, or have some sort of that if it's big enough. I'm not sure, but it's really common. That's why you usually say that you're not allowed to drink if you have a stroke until you test it. But if you have a glossopharyngeal, then I will want to test very, very carefully the accessory cranial nerve. Can they lift their shoulders? Can they put out their tongue? Because these are in synergy with you. They lie at the same place. So that's how you can use, like, these are some of the pearls in the rule of 4. If you want to know all about it, then you should check out Life in the Fast Lane, or you check out the original article by Peter Gates, The Rule of 4 and of the Brainstem, a simplified method for understanding brainstem anatomy and brainstem vascular syndrome for the non-neurologist. Okay, that's all I'm going to say about the brainstem. Remember, it's crossed symptoms. Ipsilateral on the cranial nerve side, contralateral on the leg and arm side. And also remember that if you have a Horner syndrome, that is not a cranial nerve. Okay, I'll give you a case later on, but that is not a cranial nerve, so that doesn't count if you have a Horner syndrome. Only you need to have other cranial nerve symptoms as well. Okay, then we move on to another area of the central nervous system, which is the eyes. And this is like a mini lecture in the mini lecture. I'll do a mini Neuro Ophtalmology intermezzo because I've done this lecture a couple of times, and a lot of this is from Tim Root's atlas, which I highly recommend, and I will use some pictures from there as well. I highly recommend his stuff, so please go in and check that out if you are interested in ophthalmology and neuro-ophthalmology. Also, as an emergency physician, he has great stuff there. Some of these, and the Opto book, which is free. Okay, just right off the bat, in general, there are these rules of thumbs. 2 eyes means neuro. If you're affected in both eyes, then it's neuro. If you're just 1 eye, then it's usually ophthalmological. Anisocoria, small studies though, but studies do show that around 20% of the population do have anisocoria in some sort. So when they come in with headache and you check for Horner's, then you want to see a picture from before you do a CT angiography, unless you're really sure that this is a Horner's, because that can be hard to discern sometimes. If you have anisocoria in your patient with a GCS of 15, which is something that I often get consulted on, a patient with anisocoria who had a bump on the head, GCS 15, oh no, they have a pupil that doesn't, maybe it react, maybe it doesn't, and they have at least they have anisocoria. The one pupil is not as big as the other. Should I be worried? In general, as a rule of thumb, if they have a GCS of 15, then you don't have a bleed that can cause a anisocoria and fixed light pupil, which is what we are concerned about. So, but just a minor thing about head bumps. We often scan patients right away, and that's actually to find the acute subdurals and the epidurals, right? But usually when we send them home, we should always, that's why I say yet, because when we send them home, we should say, well, especially the subdural population, the risk, those who are at risk of subdurals, the elderly, the alcoholics, and the ones on anticoagulants, that they might in the next couple of months develop this, and they should tell their loved ones about if they become weird or demented. They should do a CT scan to check that out. Okay. Neuro-ophthalmology is a big mouthful, and it's a specialty in its own. For the ED physician, I want you to know about a few diagnoses. I want you to be able to discern a cranial nerve 3 palsy. I want you to know about the painful Horner's, the temporal arteritis, the giant cell arteritis, and a bilateral abducence palsy. These are some highlights. There are a few more, but these are the common and common-ish, and you'll miss it if you don't know about it. Okay, so eye stuff in general. In neurology, there are 3 things that we need to know about. There are eye movements disorders and diplopia, which they go together. Then you have your ptosis and pupils, and then you have your sudden vision loss. These are the 3 neuro-ophthalmological presentations that you want to know about. So if you go through the first one first, the diploplia and the movements, then the movements can be either you have a lesion, either you have, if you have eye movement problems in both eyes, like they are in sync with each other, then you will think brainstem or above. If you have 2 eyes going in different directions, this will almost always call diplopia. The above one will not usually cause diplopia, and then you will think brainstem or distal to that, meaning it might be a peripheral lesion in a cranial nerve to the eyes. Okay, so if we go through the above the brainstem first here, then these are a couple of patients that we might see. So here you have a patient with a conjugated, meaning that both eyes conjugated and horizontal, going in that direction, gaze palsy, meaning that they only look in that area, right? They only look in that eye, in that direction. If I do what we call a doll's eye test, if I try to twist the head in that direction or that direction, the patient's head will look like a doll's eyes. They won't move. Usually, you will have your eyes will center. So if I moved your head that way or that way, your eyes would move, would like look straight ahead, and they would move in your head. But here they are fixed, and that's what we call a doll's eye positive. So this patient has a doll's eye positive to the right. The eyes don't go over the midline, and weak in this arm. Where is the lesion? So we know from this, we might know that if you have a big lesion in your hemisphere, then you will look towards your lesion, right? So that makes sense. Looking towards the lesion and has a palsy in that left arm. So that's a lesion in your brain here. This guy has a lesion here, but is looking in the other direction, and that's the opposite thing. If you, I usually remember it like this: like a lesion, a stroke will pull your eyes towards you. You will look towards it, and the opposite is the epileptic seizure, where you will have the eyes looking away from it. So the lesion is still here, but there's just an epileptic seizure going on as well. That's why the patient is weak here. The seizure is here, and even there might be a stroke here causing the seizure. But because of the seizure, the eyes are being pulled in that direction. And then these are the two main ones. These are really important ones that we need to know. This one is quite unlikely. You have the opposite of my rule here. You have someone with a weakness here looking in that direction, but there's no signs of seizure. And that's the exception to the rule where you have a brainstem infarction in the mesencephalon, I think it is. Okay. Let's do a small case. So these are the two I want you to know about. The other one is like unlikely or rare. So let's take a case. 80-year-old female with weakness in her left arm and has a conjugated palsy to the left. What is the cause? So this is actually the gentleman we see here. That's the kind of syndrome. Left. This woman was not shaking or anything, and you can have a non-convulsive epileptic seizure, and that's important to catch, because if you don't, then they won't get their. It's not as important as the status epilepticus, but a convulsing status epilepticus. But it is important to catch these, and that's what you will do if you know that when you're looking, if the weakness was caused by the stroke in the right hemisphere, then they would be looking towards the left. If anything, they don't have to. It has to be quite big strokes for them to do this, but at least they shouldn't be looking in the other direction, and that means there must be a seizure. Yeah. Okay, and this is a rarity. But I have seen it a couple of times in the ED, at least 2 times in the last couple of years, and it's something that I mean, usually it's so obvious that you will anyway do some further workup, so it's not important to know about. I just thought I wanted to take it with you, give it to you here. So this is an internuclear ophthalmoplegia, and it's kind of it's very specific for MS. If they only have that, it's a lesion in the brainstem on the in one of the nuclei, and it's very it's very specific, and it looks like this. Like you have an nystagmus when you look to the right. If you say the patient looks to the right, they'll have an nystagmus on that eye, and their left eye will have an adduction deficiency, so they can't look to that. They can't look that way. So they usually come in presenting of double vision. Okay, and then you have your vertical gaze palsies, and these are always highly concerning if you have a vertical gaze palsy. or if you have if you have sun setting, meaning that you might have a hydrocephalus or some kind of increased intracranial pressure thing. So anything vertical is always concerning. Ask a neurologist for details. Part of this vertical thing makes a lot of people think about the HINTS test, and I just wanted to take this with here. So you have your HINTS test, which you will use for specific dizzy patients. And the HINTS test signifies HI, which is head impulse test, the nystagmus, and the test of skew. We have done a lot of videos and podcasts on this topic on the Acute Medicine on the homepage, so please go and watch those. I've even written a chapter in the book that I'm also co-editing. And very recently, my very my very productive and brilliant colleague Emil has done a EBM walkthrough in this topic on the HINTS test and whether we can use it in the emergency department or not. Okay. The way I present the HINTS test, I want to have the nystagmus on the top because that is the inclusion criteria to use it. So your inclusion criteria to use this test is if you have a continuously dizzy patient who does not have, like most patients will feel better when they lie down, significantly better, and then they will go away after a couple of minutes. This is not your patient. This is the patient where it doesn't go away. And it's, even though they lie still for 5 or 10 minutes, it's still there. And some PPVs really, really early on might have this, especially if you've been shaking them around for a long time. But in general, these are not hard to pick out. I find usually it is obvious, and you will then when you have them lying still, you want to know, do they have nystagmus or not? Because if they have nystagmus, then you can do the rest of the HINTS test, meaning usually the HIT, the head impulse tests. So I'm getting ahead of myself. So the HINTS test here is there are 3 tests: the nystagmus test, the head impulse test, and the test of skew. You have a central or a peripheral. It's like dichotomous. So either you have a central or you have a peripheral outcome. And if you have any central, then it will then you cannot rule out a stroke. You will do a CT on them, and you will, depending on their timing, either do a CT angio and speak with a someone with thrombolysis or a embolectomy, depending on the other symptoms, or you will just give them aspirin and make a neurologist look at them tomorrow. So the nystagmus thing is that you have the central kind of nystagmus is if you have a bidirectional. So look to the right, they have a nystagmus going to the right, and with the fast going to the right. And if you go look to the left, then you have they will change direction, or you will have a vertical nystagmus. These are highly pathological, and you will have to this is highly suspicious for stroke. The other way around is, and that's the usual thing, is that it's only a nystagmus in one direction, right? And it might follow what we call Alexander's law, that when it goes in one direction, it's really, really fast, and when it goes the other right direction, it's still beating towards the right here, but it's slower and maybe be gone at all. Okay, so then we have your HIT test, your head impulse test, and you have what you're looking for is whether you have a catch-up saccade, which will signify that you have a peripheral lesion, and that should usually be opposite their nystagmus direction. That should be opposite their nystagmus direction. And then you have your test of skew, which either is present or not present. Is really low sensitivity thing. Not many people had this, but they might. But if they have it, it's highly pathological. Okay, so what you want to do, what I want to signify here there are a couple of things I want to signify, because the hints test is something that we often get wrong. It's important to say that you have to choose the right patients. You cannot choose any dizzy patient. It has to be a monosymptomatic, meaning no neurological symptoms besides dizziness. So you have to examine them first. And that means also they're not allowed to be very ataxic. They can be mildly ataxic when you're up and walking them around, but usually these patients don't want to walk. So they have, but in general, they should be monosymptomatic, and they should be with a nystagmus, spontaneous nystagmus, meaning that they should be AVS, right? They should have acute vestibular syndrome at presentation. The definition of acute vestibular syndrome is beyond 24 hours, but a more pragmatic way of saying this is like constant dizziness in the emergency department after lying still in maybe 5 or 10 minutes. And then when you look at them, they have a nystagmus. Another pitfall is, and the problem is here, that if you choose the wrong patients, I mean, it's the hit test that is bend or break, because the hit test is so hard to discern, and the defaults that like all patients have a normal hit test if they're not dizzy. So and a normal hit test will point towards a central lesion. So that's why you have to really pick out your patients. Otherwise, you'll just get a lot of false positives. If you're in doubt, you can always do the CT and call the neurologist. But in general, the HINTS test is in good hands, expert hands, better than an MRI. The MRI you should do after 48 hours, because the CT scan will not pick up anything less than very, very big strokes in the back of their head. Yeah, and the MRI has an 80% sensitivity after 48 hours, I think. So yeah. But so one of the other common pitfalls is that you don't make the patient lie still, and the BPV thing, sometimes they can have an AVS-like presentation. It might have value if you're in doubt, even after 10 minutes, to do the Dix-Wall Pike to see if there's very, very obvious very obvious BPV signs. And if there is, then this is where one of the reasons why we want to know about the BPV, because, well, then you can probably rule the other one out. Another one is that you're not assessing the nystagmus at a 2/3 of the extreme angle, meaning that if you say that the patient looks to the right, then they will look in their extreme angle, and everyone has like an extreme angle nystagmus. A few beats. It has to be continuously, and it has to be around 2/3 of the angle. So you can usually, if you're using Frenzel, you can make them look at their thumb, and then you can control the thumb, saying that look to your thumb, and then you can like move their arm to the angle needed to assess the nystagmus. If not, you have to do that with your own hands. Okay. Another pitfall is that this is only there are other central lesions then that are time critical than stroke. Wernicke's encephalopathy, for instance, might rarely present like this as well. Then the problem is with the terminology. Avoid when you write your assessment of the patient, avoid saying hints negative, but because it might, if I read that, I would think this is a stroke, because hints negative, or if all the tests are negative, then the hit would be negative. That means a stroke. So say that, describe what you're saying, what you're seeing is the easiest way, and don't say positive or negative hits or hints. Yeah, exactly. This is also a thing. This is a rule-in test, but a rule-in test doesn't mean that you have the disease in order. If you have a test of skew that is positive, then probably, yeah, you have some kind of central lesion. But if it's just the hit that is negative, then it's probably I mean, then it might just as well be me who can't see anything, or it's hard to examine you or whatever. So don't tell the patient you have a central lesion. Just tell them, I cannot rule out a central lesion. We have to admit you, but we'll have someone look at you tomorrow, and then we'll, like that, right? So be careful or mindful of your communication to these patients. Yeah, and this is like, HIT is hard to conduct. Everything lies on the HIT test, in the HINTS test. Like, if you choose your patient right and you see that there's nystagmus, then it's usually the HIT test that is the bend or break moment, and it's hard to do it, and it's high false positive rate. So anything you can do to make that even better, maybe a camera or a high-speed camera or a Frenzel or even your phone filming the patient, that might be a good thing. Make sure that you delete the footage afterwards. Okay, and then it's the Qatar study was done by experts. This is problematic because we're not neuro ophthalmologists, we are emergency physicians, and we might not do this on a regular basis. Therefore, the sensitivity and specificity in the study is not generalizable necessarily. Okay. Then we move to the brainstem and below. In the brainstem and below, you usually, unlike on the brainstem and above, you will usually present with diploplia or double vision. And with the patient presenting with double vision, you will have these kind of you will have this mind map, and this is key as well. First of all, you want to know, is this monocular or is it binocular? If it's monocular, meaning if I place a palm on my right eye, then if it's binocular, then I can see all right with both eyes singularly. But if I see with both eyes at the same time, then I will see double. So the vision, it seems like my eyes are misaligned. That's the way to think about it. The monocular one is something. Think of the eye as a glass that has been broken, right? There's which is usually the cause of it as well. Like something in the eye has been broken. That's why I'm seeing like in a prism, or I'm seeing double. And when you ask the patient to take a hand to one eye, then one eye will be good, the other one will not be good. So that's how we discern monocular and binocular, and that's like 90% of the workup. Okay, then so because the monocular is usually ophthalmological, there are certain non-ophthalmological causes, which would be temporal arteritis or MS. Can sometimes tell you that it's monocular diploplia. If it's binocular, both eyes are seeing good, but in sync they're seeing double. Then either it can be one or more eye palsies, because one of the muscles to the eyes are not doing as well, and that can either be one palsy, meaning like the third, the fourth, or the sixth, or it could be multiple palsies at once. And if it's multiple palsies at once, you will want to think about where are they meeting, and they meet in the sinus, the cavernous sinus. So you might have sinus cavernosus syndrome, which is really, really acutely and concerning. Okay, what might misalign the eyes besides the muscles not moving as they should? Well, it's something pressing on the eyes, right? So might be a local cause, might be a tumor, might be tau, like hyperthyroidism associated ophthalmoplegia, I think it's called, trauma, like retrobulbar bleeding or anything like that, even entrapment from a blowout fracture or something like that. All of these things are concerning us as well. There are a few pearls here I wanted to talk about. So if you have double vision, a lot of people can say, I'm seeing double. But before moving into, is it both eyes or one eye, it's important also to know, well, is it, first of all, is it horizontal or vertical? So is it on top of each other or is it beside each other? And that's mainly here. It's like the palsies you can discern like that. And it's important to know, well, I can subjectively feel like I'm seeing double. If I have 8 beers, then I might say I'm seeing double, but it's not really double vision. So how do I discern whether it's a subjective or objective double vision, like real double vision, or just feeling like it's double vision? Well, one of my pearls for this is you should, like, a real double vision will look, a real binocular double vision will be worse in the area where the palsy is, right? So if I have a abducens paresis on the right eye, then I will feel worse if I'm looking to the right, because then that's the area where my eyes are the most misaligned. And if so there will be a general difference between depending on which area where you're looking. So when you do your H test or your eye movement tests, they will usually say it's worse here, or it's better here, it's better here. Your more unspecific, oh, I'm seeing double kind of presentation in the emergency department, as we get sometimes, will not say that. They will usually be unspecific about it, or not consistent about it, or not say anything about it at all. And this is also important because not all palsies are easy to see. Sometimes you need fancy eye equipment, neuro ophthalmological equipment, to actually see it. So it's important to know that there is an objectiveness, the objectiveness, like thinking that you can see a real eye palsy, is not always the case. So knowing that it gets worse in one angle, that makes the diagnosis of this being a real palsy, even though you can't see anything, more likely. Okay. So these are the tips for the ED. So you want to discern, is it horizontal or vertical? Meaning that if it's a horizontal, then it's usually the 4th. If it's vertical, then it's more likely the 3rd or the 4th. Sorry, the 6th and the 3rd and the 4th. This is what I was talking about. Is it worse in the angle of the palsy? If it is, then it's more likely a real pulse, a real binocular diploplia. And if not, it's usually unspecific. Are they dizzy? Have they been drinking? Something like that. Are they nervous? You want to discern whether it's binocular or monocular. Make them just put a hand to their one eye and then the other one, and see if it's the same or worse. Risk factors for vasculopathy, because that's the most common reason for binocular vision. For binocular double vision. Is there pupil involvement? That's really important because of the ocular motor. And then there's exam tips here. And I'll get back into this, but I think the neuro ophthalmological lectures are usually quite hard, and it's hard to know, like, don't think about which way the eyes might be moving in all directions. Just think about how would they look like if there is a lesion. So the 3rd will be down and out. The 4th will have an upward shoot, and the 6th will have a they will squint towards they will have a nasal squint, looking in towards the nose when you're looking at them. And then you might want to do a pinhole test sometimes for the ophthalmological monocular ones, but that's not that important. This was just to indicate what the difference is between horizontal, seeing two things beside each other, or vertical double vision, and monocular. Okay, so here is what I was talking about. These are the 3 palsies, and you have your down and out here, with a pupil blown out and a ptosis. That's the 3rd cranial nerve. You have a patient with what we call nasal upward shoot. That's how you discern that one, nasal upward shoot. And then you have a person, when they're looking at you, they are squinting with a nasal squint. And if maybe it's not always obvious, but maybe if you're saying look to that side left here, then they will have a abduction problem. That's the sixth. There are different reasons for the palsies, and that's why it's important for the emergency physician to know about these. You can have the third is highly concerning for aneurysms, especially if you have a blown pupil. There are other reasons, but that's the main reason we want to pick up in the emergency department, do a CT angio to check that out. The fourth is not that important in general because it's really, really weak. The path in the brain is quite, it's like very thin, or it has a really, it's high. If you have a head trauma or a bump on the head or something like that, then sometimes it might go loose or it might break. Sometimes it's congenital even. So the fourth is not that concerning. But the sixth might be concerning, especially if it's bilateral, is really concerning. But if it's unilateral, and let's say you have a 40-year-old female who is quite overweight and has a headache, and also has this abducens problem, then you might think idiopathic intracranial hypertension. And intracranial pressure, for some reason, the abducens paresis is more common with increased intracranial pressure. So this was a down and out. They will usually if you ask them, say they have binocular vertical diplopia with maybe with a pupil involvement, which is concerning. Then here you have a nasal upward shoot. They will usually have a vertical or oblique, if you want to go into details. And these will usually have this look towards the nose, a nasal squint, and the horizontal diplopia. This was the sinus cavernosus syndrome. So just to say that if you have more than one palsy, you want to think about the sinus cavernosus because this is where they collect. Okay. What is this? And I'll make you think about it. But this, you see, first of all, it can be hard to which eye is the problem. That's why just make the patient see straight ahead, and that's usually how you will get the diagnosis, and then do the H test. But think about the three pictures that I just showed you, and then you will usually be able to see how the pathology looks like. So down and out, blown pupil, and ptosis, big ptosis, an ocular motor. The reason why the pupil thing is really important is because the superficial parasympathetic nerves are running in the periphery. So if you have an aneurysm pressing on the nerve, then you will have a pupil blown. That is less likely if you have something going through a vasculopathy. A vasculopathy will hit the nerve in the middle. So that's why the vasculopathy, which is the most likely cause of all of the palsies, like if you have your fat, diabetic, hypertensive patient who doesn't take his medication, that's usually the patient presenting with a palsy. But you have to always think about these things, especially if it's painful. Okay. Just a small nuance here. The concerning things about the third cranial nerve is if it's the 3 Ps: partial muscle involvement, progressive, and pupil. Especially if there is any other cranial involvement, then it might be a sinus cavernosus syndrome. And if it's young age, and if it's a painful onset, these are concerning because usually the ones who have palsies are the fat, hypertensive, diabetic, right? But we are Bayesians and probabilisticians, so. All right, then we move on to the next kind of presentations with eyes, ptosis and pupils, and we'll start with pupils. So pupils is usually the anisocura. And I mean, as I said, it's really pretest probability specific because 20% of the population will have this sign probably. So you always have to take it in context. You have either mydriasis, where the pupil is big. What you want to think about is the third cranial nerve here, or the traumatic bleed, of course, but usually the context will tell you. And if they don't have any palsy, I would probably not think about this. Of course, you can have a semi-dilated, painful glaucoma, but usually the mydriasis is really context specific. I would not be concerned if someone suddenly are stable and they have a mydriasis. I would, however, consult someone, but I would just not be that concerned. Because the most common thing is that maybe they rub their eye with something. It can be certain flowers can do this. The belladonna droplets that you get with the eye doctor can do this as well. And if you use cocaine and you touch your eyes, then that sometimes will do that as well. And that's usually, I've seen a couple of these in the emergency department, and it's almost always these. You can have your physiological anisocoria, of course, but and if you're in a really dark room, then it might look like this, but put them into a light room and it will go away. And then you have your 80s tonic pupil, which you will have to look up, but it's a semi-rare condition where you can have a pupil that is tonic. Okay, then you have your meiosis, and that's much more concerning if they have a meiosis, because the time critical thing is the Horner syndrome. So if they have a ptosis and meiosis at the same time, the third one being anhidrosis, meaning that they cannot sweat, but that's rarely tested. So ptosis and meiosis, then you will do then you will be concerned for Horner's, and I will tell you why you should be concerned. The other common ones here is eye trauma. Okay. Moving on to the ptosis. I want to like the pearl here about why do you get ptosis. There are two. So we saw that in the part 1 that the facial palsy cannot close your eye if it's peripheral. That's because the 7th nerve is the one that closes the eye. So if you have a peripheral nerve damage in the eye, then you will not be able to close your eye, and and that's the sign there. Then you might have and the one that opens the eye is the third nerve. That's a big opening. You have a small opening in the Müllerian muscle, which is sympathetically. A lesion here, the sympathetic one, will give you the Horner's, and a small ptosis, a lesion here in the big one, which would be the third cranial nerve. Then there you will give a big ptosis. Okay, so small ptosis, sympathetic lesion, you think Horner's. And it's really discrete here. A lot of sometimes you have to look at older pictures because older people might have a bit of droopiness there as well. And it's quite common to have some droopiness, but it has to be new droopiness, right? And with a meiosis. And you can have a big ptosis, and sometimes the eye is totally closed, and that's not uncommon with these lesions. And then you can have a bilateral ptosis, and that you might think of myasthenia gravis here. Okay. This is a key thing. I've been talking about Horner syndrome, and Horner syndrome is really important because you often miss it, and there are some concerning things to be aware of when you have a Horner syndrome. So I wanted you to think about the Horner syndrome as the Horner's U. There's a U going from the vasculature down to the medulla up to the brainstem. And there are 4 areas here where you want to be concerned. If you see a Horner syndrome, you want to think about these 4 diagnoses. Okay, so the first one is the internal carotid artery dissection. The second one is the Pancoast tumor. Usually, if you have a patient with a numbness in their left arm and they have a left-sided Horner's and they've been smoking, then that's a Pancoast tumor until proven otherwise. You might have someone with a high cervical lesion, high medullar cervical lesion. That is usually a traumatic lesion. They will have a Horner syndrome. And you might have a lateral brainstem infarction or a vertebral dissection, both of these can give the. So if you have a patient presenting with a Horner syndrome and headache, or pain anywhere around the neck or head, then you will have a high concern of cervical or vertebral dissection. And if they have any, and that's usually where you want to do a CT angio to rule out that diagnosis. Just to this is a very obvious Horner's, and just to make where you want to this is a U shape, and think about the Horner's U. Okay, the last one is the sudden onset vision loss. So remember I talked about that 2 eyes are neurological, 1 eye is ophthalmological. Well, it's all because of the optic chiasm. If you have something behind the optic chiasm, then you'll have both eyes involved, because the strings from these strings are being crossed like that. Yeah. If you have something in just this, like what we call pre-chiasmal and post-chiasmal, if you have a pre-chiasmal lesion, then it's usually the eyes. You can have nerve damage here, which is why MS will present with monocular problems, and other stuff like Toulouse Hunt and stuff like that will present with monocular problems. But in general, it's usually ophthalmological. The things I want you to, as an emergency physician, to know about is that monocular vision loss, you have to think about amaurosis fugax and giant cell arteritis. And we did a case in the part 1 about that, where I detailed my thinking about that diagnosis. So please go look that up again. This is Neuroland, on the other side, the post-chiasmal. Okay, then you have vision loss. If you have a post-chiasmal vision loss, you will have what you call homonymous anopsia. And I always thought that this, my pearl for this is, like, if you have a lesion, it respects the rule of thumb, which is a brain lesion will lead to a contralateral deficit. So if you have a lesion here, you will have a lesion. You will have a deficit here. If you have a deficit, this is not a 3D picture, but if you have a deficit high up, you will have a low down, what you call a pie in the floor, this problem. If you have a so this particular patient, I would be concerned that they have, so it's this side, so it would be over here, and they have a pie in the floor lesion, which means it's high up, so they will have a high up right-sided lesion, if I was going to guess. Okay. Okay, now we're moving on to the peripheral nerve. And this, I always think this is the hardest part. It might not be as hard for you if you do a lot of ortho, but I don't do a lot of ortho, so it's always been hard for me. And it's because it's also very, very specific things that you need to know how the nerves are going and so on. So I always recommend that you just have a book. Look up the charts, look up the nerves. I know many neurologists also do this, because if you're not used to working with the peripheral nervous system, then it's usually hard to remember all of the details. An emergency physician needs to know these, though. Guillain-Barré, Cauda Equina, hypokalemia, and myasthenia gravis. These are some of the most important ones that I want you to be able to discern. So this becomes highly important now. This picture again. That's why I'm showing it to you again, because most of these, whether it's peripheral or central, can be discerned quite easily, because these patients usually don't present hyperacutely. They will usually present after a couple of at least hours, but usually days. Okay. So these are the mental models that we want to think about here. and we're moving in close in this area. So if we move in closer, you have your medulla, and you have the roots going out here, and then going into I think it's called the trunk, and then the nerves, and then you have a muscle. I'll just pinpoint here. So I'm not as concerned about the details of this. I just wanted to show you that, well, that there are different, there are some nuances here. So as we talked about, this is a paraparesis if you have any medulla involvement, but almost all neurological conditions will have will follow a dermatome or a myotome, but plexopathies, and a plexopathy might be if you're having a trauma in your shoulder or something like that, where the plexus is being torn, then that will not follow a the usual like dermatomes or so, and you might think they're functional, or but just have in mind that they can present with something that doesn't really respect the dermatomes. The main the root lesions will be more will follow dermatomes, so will usually be like this is like I think it's like T6 or something like that, and these peripheral nerves will usually look like this. You will have peripheral nerves with distal sensory or motor problems, or you can have a mononeuropathy where it's only one. You can also have something called mononeuritis multiplex, where it's more randomly scattered, several mononeuropathies. Then you have your muscle, which is not, which we'll get into in a little while. But how these can be quite hard to discern, and that's why I wanted to show you this slide and say like the distinguishing features of these is these two look like each other, but the distinguishing feature here is this is how you distinguish muscle from nerve is that these are proximal, and these are motor, not sensory. And if it's and how you discern these two from each other is this is fatigable. A myasthenia gravis is fatigable, so if you do it 20 times, then it's fatigable, but then it comes back really quickly. There are specific tests like Jolly tests and ice on ice tests that you can do, and usually you'll do a neo-Stickman test if you're really concerned. Okay. These are the diagnoses that I want you to know about for these and how they present, right? And we'll go into first the nerves here, and these are the neuropathies. Like you have a polyneuropathy and you have a mononeuropathy. Let's go into the polyneuropathy, meaning usually there's some kind of systemic reason for why, because it's on both sides, right? It has to be systemic then. Could be a medullary lesion, but that's more rare. And usually it's on both sides here. So it's some kind of systemic, not focal. Okay, so they will usually present like this, looking like their finger, the long nerves are getting hit first. So that's usually the legs first, and then you have your arms. So that's the polyneuropathy picture. Neuropathies are highly complex usually to discern, but and they can be put into different groups, and depending on what you want to know about. But in general, for the emergency physician, I think it's important to say that it's a motor, is it sensory, or is it mixed? Like, is it only motor? Some of them are only motor, like Guillain-Barré is only motor, and it's not actually, it's a polyradiculopathy. It's not a polyneuropathy, but it's a minor detail. It's a motor. Some of them are sensory, and that's usually the more chronic ones that we will see. The sensory polyneuropathies are usually we usually see them when a patient has some kind of I mean, the main reasons for sensory, like any polyneuropathy, is like it's three causes, like it's alcohol, it's diabetes, and it's kidney disease. These three are the ones that are the most common, and if you have an infection on top of that, then usually it become a little bit worse for the patient, and that's usually when they will be annoyed by it and tell you about it. But usually, other reasons why we might encounter this is when you have your quote unquote dizzy patient, your elderly patient that is falling might have a component of polyneuropathy, which might be important to pick up, because that is something you want to work them up for, or at least make the ones who is working them up for falls be aware of this, because it's they will fall again, because it's usually not something that can be fixed. We talked about polymono and mononeurotic multiplex. You have the demyelinizing and the axonic, and the axonic is the ones that where it usually doesn't get better, and the demyelinizing might get better. Most of the sensory ones that I just talked about are axonic. That's why they won't usually get better. Then you have traumatic and non-traumatic, but these are the ones that I want you to know about. Okay, so. Yeah, as I told you, I'd say around 90%. Usually, I mean, I don't know if that's the right number, but a large amount of these patients have, with the sensory, has chronic kidney disease, alcohol, or diabetes. It's just, and the rest might have some might have had oncological medication or other something like that. There's a tiny percentage that might have B12 deficiency and stuff like that. Okay, this is just to show you that you start off with slightly sensory loss in your legs usually, and this is the sensory polyneuropathy. Then you move on to more, and then, as I told you earlier on, that the wraparound nerves here will also be damaged after a while, and then you will have stomach problems as well. Polyneuropathy that we usually don't talk about is the autonomic neuropathy, and autonomic neuropathies are something that we might want to know about, especially if you have a Parkinson patient. They will usually have, they might have obstipation and orthostatism, which is concerning or if you have a patient with both these things, it might be an early presenting symptom of Parkinson's. I wouldn't work them up, but it's just, I mean, something to something to have in mind. Then you have your erectile dysfunction, which is also an autonomic neuropathy. And if you have someone presenting with erectile dysfunction, or then it's a highly and they don't have a diagnosis of diabetes or something like that, then I would really work them up for risk factors for cardiovascular disease and diabetes, because that might be the first sign of that. If they don't have any other obvious reasons for erectile dysfunctions, like psychogenic. So if they're really young, I would probably not work them up. Okay. So that was the polyneuropathies. There's a lot to be said, and we don't usually have to know too much about it in the emergency department. Then there's the mononeuropathies, which are more common in ortho, especially because there's a lot of traumatic mononeuropathies. As I told you, these are hard to discern sometimes, and I usually use an atlas if I really have to. We have dermatomes and myotomes, dermatomes being the sensory part of it, and myotomes being the muscular part of it. And the muscular part of it would be reflexes and whether or not they're weak, and the dermatomes would just be the sensory part. Okay, just reminding you that if you have a whole body part, like a thumb or a foot, being affected, then you should think about homunculus stroke. Okay, so just quickly, there's a really quick test to like the quickest test you can do to screen for mononeuropathies in your hand is to do a OK sign, where you do it shouldn't arc here, it should be good and round here. A median nerve does that. Then you will have the patient spread their fingers with these 3 fingers, then that's the ulnar nerve, and then you will have to extend the wrist, and that's the radial nerve. So if you can do the OK sign, especially in children, this is great because then you know that they're all right. And well, yeah. Otherwise, I will look in the atlas to check out the other the other myotomes or the other muscular involvements of these nerves, and also the dermatomes. But this is just a quick pearl. You have the reflex man. If you want to test some of the myotomes, and the reflex man goes like this. If you put someone on their head, then the Achilles is 1 and 2. The patella is 3 and 4, and like the triceps is 7. The biceps is 5, and so it goes like 1, 2, 3, 4, 5, 6, 7, 8 in terms of reflexes. If we go to the foot and the leg, then it becomes more important. It also becomes more important, but probably a little bit more important usually because more concerning things can happen in the legs than in your arms. Especially if you have someone presenting with back pain, where you want to check up Cauda Equina. So this is where you want to know about the myotomes, especially these. My mnemonic is that if you dorsiflex your foot, then it's the L5, and you know it's the L5 because you look like an L shape when you do that. And if you do a if you want to do the extension here, then you will look like kind of like an S, right? So it's a rheumatologist who gave me that mnemonic I've been using. And then you have your dermatomes. So let's take a case, right? Because this can be quite tricky. So let's say you have a common presentation where you have someone presenting with a drop foot, a traumatic drop foot. So where can that be? Well, usually you will say, well, that's a peroneal nerve damage. Well, yes, I agree. That's the most common, and that's but we don't think about the most common necessarily in the emergency department. We think about other stuff as well. We think about the time critical stuff, even though it might be uncommon. But if it's still above the treatment or diagnostic threshold, and that might only be 1 or 2% for certain diagnoses, then, well, I'll work it up. And the Cauda Equina here is a time critical one, and if you present it with a motor deficit in the leg, I will think about it. Could this be a homunculus stroke if it's the entire foot, and maybe it's a non-medical one, meaning that it might be a non-neuro one, meaning it might be either a software problem, of course, but might be a mimic. So maybe Achillesine rupture. You can do a Thompson's test there, or it might be an acute ischemic embolus again. I would say that the precise probability of this would be maybe 65% of this is so common, and it's a drop foot, yeah. Here the Cauda Equina is quite rare, but they can present with motor deficits on the legs. Homunculus strokes, I really need to see that specific sign of all the entire chunk of the foot is not moving. And here, as we have sometimes been fooled by this, especially so this is on the radar, but it's not that common anyway. Okay, again, give me 3 questions or exams you want to do next. So this time I'll just give you the answer. What we want to know is actually just one thing: how does the foot move? It's kind of the same as when I have the thumb case. You want to know the other stuff as well, but I mainly just want to know how does the foot move. And there's a special movement in the foot that can make me. So let's say the foot is moving somewhat, so it's not a homunculus stroke, and the Thompson's test is negative, and so then the main battle is between, is this an L5 Cauda Equina lesion or is this a peroneal? Because if it's an L5, then I have to work up for Cauda Equina MRI acutely to a neurosurgeon. but if it's not, then it's just a minor thing to do in the emergency department. So how do I discern these? And I'll summarize this for you. There's one movement that is important. This is the eversion and inversion. So if you have a drop foot patient, you will do this. The eversion or the inversion. So all of your patients will be able to evert, but only some of your patients will be able to invert. The ones that cannot invert their foot is concerning for Cauda Equina. That's the pearl. Okay. Moving on. Now we go to the muscle part. Okay. So as I said, the gestalt for your myopathy is the proximal symmetrical weakness. These might be genetic, and we might not even want to talk about these because, I mean, the genetic ones, some of them present in later age, but usually they're picked up in childhood and they're followed and they are known about. What we do want to know about these is that your dyspneic patient who has a myopathy can become quite bad quite quickly because they don't have that much muscle, so they have a mechanical problem on top of them having maybe a pneumonia. So you will be concerned about these in another way than we would a normal individual with a normal musculature. What we do want to know as emergency physicians is hypokalemia and myasthenia gravis and maybe polymyalgia rheumatica, but that's not it. That's one of the benign ones that might be good to know about, but not necessary. And I'll give you so the myasthenia gravis. Usually, what I want you to know about here is that if you have a myasthenia gravis patient, they can come in a crisis if they are infected or if there's other triggers with a problem. And if they have a crisis, then they will stop breathing after a while. So it's really important to know the workup for a myasthenia crisis and what to do about it. A pearl here is to both for the Guillain-Barré patient who where you're concerned about when they are going to stop breathing, and the myasthenia gravis patient. You might not always be able to know whether they're you might not always be able to reliably track them in the emergency department, whether their breathing is becoming worse or better. And one way to do it is doing a single breath test. So ask the patient to take a deep breath and count as long as they can. So they might be counting 1, 2, 3, 4, 5, 6, 7, 8, onwards until they can't breathe anymore, or they have to catch the breath. And do that every 15 minutes, every 30 minutes, and see if they're becoming worse. I've had a few patients becoming worse in the emergency department with Guillain-Barré. So if you have a big delta, meaning they just went from 50 to 30 in a couple of maybe an hour or so, then it's highly concerning. If they are below 20, that is also highly concerning. Okay, for the rest of these, I'll give you a case. Okay, so this is a patient I saw in Denmark, where so young guy coming in with weakness. He woke up in the morning with weakness in his arms and his legs, and he had to he tried to stumble out of bed, but he fell to the floor. Has no history of anything other than maybe a migraine now and then. Doesn't take any medications, not allergic to anything. What could this be? Well, we took the usual blood samples, and we were concerned because he has proximal new onset neurological symptoms. But we wanted to work. We thought, well, is this medical? Is this neurological? Is there a lesion? And if there is, where is it? So let's just cut to the chase, and this is the ECG that we took. So is there any features in this ECG that might point you in the direction? So there are U waves. U waves are something that you might see with your hypokalemia. He had a potassium of 1.8, this guy, and it turns out, which I didn't know at the time, that he had a familiar hypokalemia syndrome. So these presentations do exist, and usually it's something else. Then usually it's the older patients with hypokalemia that become weak, and maybe even they have some kind of rhabdomyolysis because of statins. These are usually the patients who come in with proximal leg or arm weakness. So proximal leg or arm weakness, think hypokalemia, think statins like rhabdomyolysis or something like that. Think, well, rarely think myasthenia gravis, but it is something that is out there. Okay. Moving on to the medulla. The medulla is quite hard to go through. This is also one of these. There's a basic level and there's a complex level. I'll give you this. This is the pearl about this. Like I told you that the gestalt here is that you have para symptoms. They have symptoms on both legs, and the entire thing is like this. It's called a myelopathy. And they will have this, they will usually have a triad of sensory level, meaning they feel like a tightness around their stomach, chest, or depending on where it is. And it's usually when you have patients saying this, they will usually say it spontaneously. And that's a sensory symptom that is highly concerning. Sometimes it's only part way, only one way, because maybe the sensory symptom is only in that. I have had several MS patients presenting like that. So it's, I mean, this or the entire way is something that is of concern. But again, just like the brainstem, the medulla is quite a narrow tube, and only MS can do these almost only MS can do these pinpoint problems. Usually you will have problems on both sides, and that's why para symptoms is is a commonality when you have a myelopathy. And it might be, depending on where it is, if it's up here, then it's also usually involving the arms, but it's not involving the cranial nerves. But remember, Horner syndrome is not a cranial nerve. A high cervical might give you a Horner's. Okay. And then you have your bladder and anal problems. And this is something that I didn't know before going into these in detail, but I've become aware that through the cognitive psychology as well and the cognitive bias literature, that if you have either one of these, you want to work the patient up, or at least have it on your radar. We see lots of patients with bladder problems like cannot void, and how many times do you test them for Cauda Equina? Right. So let's go through this, and I think I have a case hidden somewhere here as well about this. So this is the other pearl about this. If you want to go to the next level about this, this is the mental map. So you have three pathways going through. This is the brain, this is the brain stem, and this is the medulla. It also looks like a bit like a penis, but that's how it is. So we have three pathways going through here. You have your motor neuron going through. It crosses in the midbrain. And it crosses on the brainstem level, and it goes down and out. So if you have a lesion, you will have a ipsilateral lesion there. So, and you will have a lesion there. And this is the vertical. This is the lateral view. Okay. Then you have two other pathways. You have your vibration and touch. Also, and that moves with the motor pathway. So actually, you only have to think about these two, and then the third one, which is coming, and then the third one, and that's the one that is the pain pathway. It crosses on the level and goes up there. So that's the atypical one. Okay. This is usually only. So this is usually only necessary when you it's not hard to pick up these syndromes usually, because that's the triad that I just showed you: parasymptoms, bladder and anal, and your sensory level. So but if you want to go into more nuance, this is the picture that you want to memorize. You have these pathways, that's the vertical picture, and then you have your lateral picture with your back string here, your sensory pathway moving to behind here. You have your pain crossing over in the middle here, and then you have your motor in the very front. The nervous system is built up like this embryologically, so that the more behind the nuclei are, the more behind they are, the more dorsal they are, the more sensory they are, and the more frontal or ventral, I think it's called, the more ventral they are, the more motor they are. And that works all through the brain embryologically. So that's a pearl to how to. If you really want to go into the nervous system, that is one of the big pearls. Also, you have to look at the gastrulation, I think it's called. So if you want to really know the nervous system, you have to go to the embryological parts and think of know the gastrulation, which layers becomes which, and that dorsal is sensory and ventral is motor. Those are like the big points if you want to go into that. All right. So memorizing this picture you can only have lesions in the medulla in so many ways, and that's why we have certain syndromes, medulla syndromes, that I will now go through. So we have these 6 medulla syndromes, and this is quite complex. So I have a triangle down there. Okay. So you have the total cord syndrome. You have a lesion in everything. What happens? Well, you have both. You have this patient who, depending on the level, will have both bladder. You will have sensory level. You will have para symptoms, and the symptoms will be motor, pain, and touch, and also vibration. Right? Everything is gone. These patients are usually traumatic patients, and they are highly concerning of something called autonomic dysfunction. Autonomic dysreflexia, and meaning that they can't regulate decently, and they might destabilize, usually not in the emergency department, but further on, and usually you will have to help them with their autonomic problem, which usually is just emptying the bladder for them or something like that. Just a small pearl with these patients. Yes. Okay. So then you have your anterior cord syndrome. Your anterior cord syndrome is your patient coming in. I once was at a neuro lecture in Denmark where an Austrian physician told about the anterior cord syndrome with if you're surfing, you can flex your back so much so that you will compress your anterior vasculature here, giving you an anterior cord syndrome, actually a stroke. And that's usually the cause of the anterior cord syndrome, that is stroke. So you might have, just as well as you have a stroke in the brain and the mesenteric emboli and so on, you might have a stroke in your anterior medulla. is rare, but it does happen. It does happen, and you will present with a sudden paraparesis, and because you also have no sensation of pain, but you have your back string is still there, so you will have sensation and vibration intact. So your patient will present like this. They usually have their bladder spared as well. So they will have a like this. They will have impaired perception of pain and temperature, and they will have a paraparesis. Okay. Then you have your, this is the hard one, right? So you will have your Brown-Séquard syndrome, your HIMI syndrome, and this is where you on the one side, on the lesion side, and you'll have to draw this out by yourself as well as it's but to make it make sense. But in general, you will have a patient presenting like this. On the affected on the lesion side, you will have the opposite of what you would think from this. You will have a motor problem here, and you will have a sensory problem here with touch and vibration. But you will have no, but you will not have anything here other than you cannot feel pain. And the way I remember this is because I think it's quite easy, because you know that the motor and these two go together, the motor and the touch. So the motor and the touch in a hemi lesion will also always be on the same side. And what is on the other side is lacking, that's the pain. So the patient will be able to feel pain here, but not here. Will not, and this side will be normal, but with movement and touch, but this side will be deficit on that. Yeah, Brown-Séquard is the hardest one to discern. Okay, then you have your central cord lesion, and these are usually this might be a syrinx, like a syringeal myalgia, where you have the central canal being weak, and then you will expand from the center and outwards over time. And there's usually a cervical problem, so they might present with something like motor symptoms. And there's like in the capsule, like the homunculus goes all the way through the brain down through the medulla, and the homuncal representation is, I haven't taken it with here, but you can find it in anatomical books, and the homunculi presentation, it goes into the capsule interna, where you in the brain where you have like legs, and then arms, and then head, and in the same way it's ordered here. And what moves out first is the arms, and then comes the legs, because that's the chronology of how you're built up. And so here are the arms first, and you will usually have what's called man in a barrel syndrome, where you have arm weakness, and they will also not be able to feel pain. But they will be able to feel touch. Another more common reason for this is a hyperextension injury of the neck, where you might think of the central canal as a straw. If you bend a straw, it will kink in the middle, and that's probably what happens in the traumatic lesions, and that will give you a central cord syndrome as well. So your patient will present like that with what you might call a man in barrel syndrome, because sometimes the entire arms are damaged, but sometimes it's only your proximal arms, being like a Tyrannosaurus Rex or man in barrel, because it seems like they're in a barrel. Okay. Then you have your dorsal cord syndrome, and your dorsal cord syndrome is something that actually is not that uncommon. All of these are quite uncommon outside of trauma, but this you do see sometimes, and at least you do think about it sometimes. If you have someone who has an imbalance, has a proprioception problem, who might walk into things and is a not a vegetarian, but a vegan, only living on maybe rice. You also sometimes see this in young people taking a lot of nitric oxide, like every week, several days a week. This is the dorsal column syndrome, and it might be B12 or nitric oxide, or there are several other causes for it, but these are some of the common ones I've seen anyway. You will have someone who will not be able to. So when we're standing on our feet, what is keeping us upright or not? What is keeping us in balance? So when you have a patient complaining with dizziness, sometimes it's everything moving around, but sometimes they will tell you it's dizziness, but it's actually imbalance, and they feel like they can't walk, and that's where your rhombus test is important, because there's a triad of things that makes you keep your balance. That is your central input, which would be the cerebellar input. Then there's your eye, your vision, and then there's your proprioception. And there's also there might be a fourth one here, but the general rule of thumb is that there's this triad, and if you remove one of them, which would be your sight, then it's all right. Then you can do with the two of them. But if you remove two of them, which would, if you have a lesion in the dorsal column, making your proprioception out of function, and you make them close your eyes, then they will fall. That's a rhombus positive. So that's one of the ways that you might be able to discern it, but it's not. It's a rule of thumb. It's not a golden rule. Like it's not because there are a lot of leeway in this. Okay, but that's the dorsal column syndrome. They will have impermanent vibration and proprioception in your leg, and usually a deep touch as well. Okay, let's take a case. You have a APC stable motorbike accident guy coming in, and you will have to do a D on the ABCDE, and on your D you will find left meiosis and ptosis. You will find a left arm weakness and left weakness in your leg as well. He might be able to just adduct a bit in the shoulder, but that's the only thing. Feels no touch on the left arm or leg, but it does feel pain. Feels no pain on the right side, but does feel touch. And bladder and bowel syndrome has not been examined. Okay. And you don't seem to find any other neurological lesions. Okay. So where's the lesion? Lots of findings here. I would encourage you to draw this patient because when there's more than just a few findings, then I encourage you to draw a patient just like you do in ortho sometimes, if you want to remember which side it was on and where the damage was. So this is a case where you might also want to think about it vertically and horizontally. So this is the patient of concern. You have pinpointed where it might be. So we can think about it like this. Are we above the brainstem? No, because there are no cranial nerve deficiencies. He might have several lesions. That is a concern if it was a great, but GCS is 15. He's good. So not as likely, I think, that it's a brain thing. Is it brainstem? Well, they are not. Again, there are no cranial nerve lesions. The meiosis and ptosis is not a cranial nerve. It's unless it's not a meiosis but a mydriasis on the right side. Then this is not this is a Horner syndrome until proven otherwise, I would say. And that's a remember the Horner's U. You had your you can have a dissection, of course, and that could happen. It could be a dissection he is having from a traumatic dissection. But I would think there would be more cranial nerve involvement there. So, or might be. But that is on the radar. But the Horner's U is like, it might be a dissection, but it might over Pancoast tumor, no. But it might be something like a cervical autonomic system problem, like a cervical medulla problem. So let's try. Okay, so laterally, motor and touch on the left, and they go together, and the right is pain. If we remember, that's the Hemi-Lesion syndrome. If don't, that's all right. It is hard, and that's why I put this triangle up here. The other one is vertical. That might be more important for the emergency physician because, well, he's ABC stable. That means it must be, if you remember the mnemonic 3, 4, 5, keeps the diaphragma alive. Well, then it must be above that. If he's ABC stable, doesn't have a B problem. He does have a Horner syndrome, but no cranial nerve. So Horner syndrome is it's either dissection or it's something in the medulla, or it might be physiological anisocoria, and he just has some damage in his in the face, making make it seem like he has a small ptosis. These are hard to pick out sometimes. And he could abduct, but he could abduct his shoulder a bit. So I mean, all of this like below C5, and he could abduct his shoulder a bit. So that's C6-ish if you look up in your atlas. So that's kind of where it is vertically, and laterally it's a hemi-lesion. So a lesion somewhere around here. I'm not saying that you should do this in the emergency department, but it's good to have, like, this is the way I would do it in the emergency department, because I want to know how concerned am I for which area. And now I'm really concerned about the medullary lesion, but if you look really superficially on this case, well, he has something in the eye. That might be a cranial nerve, and you might have to scan the head then, and you look really closely on the head, and when you don't find anything in the head, well, or maybe you do. That's the problem. Maybe you do find minor lesions in the head, not explaining this, and then he goes up to the department. He gets a terrible. He gets some kind of autonomic dysreflexia because it wasn't quite a hemi lesion. It might be a bit more than that, or you get something other complication. I mean, it's not bread and butter, this, but it's worth knowing a bit more about, and just to also pinpoint some of the things that I've just gone through. Okay, so the take home here: Horner's is not a cranial nerve. Draw a stick figure when you have multiple lesions, and the C3 to C5 keeps the diaphragm alive. Okay, here's another patient, and this is the last of the medullary syndromes. And this patient has bladder problems. He cannot void, and he even has a overflow urine right now, and he's weak in first this leg, but then this leg. I'll come back to that patient, but first we'll do this case here. A 55-year-old man presents to a walk-in clinic towards the end of the evening. He has it's a busy day in the clinic. Good with a bit of context. This is Pratt Crossgrid's case, so therefore there's always context. That's important. And he has not had a bowel movement in 4 days, which is unusual for him. Yada yada. He complains of pain in his lower back and lower abdomen, also some tingling in his legs. He thinks that he will feel better with a laxative because what he has tried so far has not worked. And he was briefly examined by the physician, who did not find anything remarkable in the abdominal examination. There was some mild suprapubic tenderness, which patients needs to urinate. Bowel sounds were good, and his abdomen was soft. There were no masses or organomegaly, so the physician prescribed a strong laxative and sent him home. That's not unusual, because these symptoms that he's presenting with are quite unusual, but he didn't do any neurological examination of the legs, right? During the night, the patient was unable to urinate and went to the emergency department. On examination, his lower abdomen appeared distended, and he was found to have a residual volume, and his rectum was markedly distended with soft stool and required disimpaction. He recalled straining his lower back, lifting about 4 days earlier, and that was the feature that that might be noise, might be signal. It's always hard in the emergency department. That's why these cognitive biases, when we look through them in hindsight, always look so obvious, but being able to pick them up when we are the one in the front line is always hard. So we always have to not judge, but think, how can we learn something from this? Learn, not blame. This patient and the other patient I described before had Cauda Equina. So Cauda Equina syndrome is one of these: saddle anesthesia, bladder or anal paresis, and motor symptoms, progressive sensory symptoms. If you have one of these symptoms, you'll have to work up your patient. These symptoms are really high signal, and this motor symptom is usually high signal. Unless it's a dropped foot, then sometimes you will only think of the peroneal nerve, but you should also think about this. The progressive sensory symptoms, these are sometimes hard to find, but just keep it on the radar. If you have someone over days having more and more sensory deficits in your legs, then it's concerning. But someone with just a stable sensory deficit is not as concerning and usually can go home. The bladder and anal paresis, though, that's hard. Anal paresis is really high signal, right? But if you have we have tons of people coming in with bladder problems, and I mean, my take home here is just have it on your radar that it could be a Cauda Equina, especially if they're not known with this, if they're presenting with the first time, if they're not known with prostata problems, if they're a woman. So do a neurological examination of the legs, or be open to the fact that they might have had back pain in their history. So that was Cauda Equina syndrome. Another pearl to know about is when you do a lumbar puncture, it's sometimes you're afraid of hitting something, but if you do, and if you os sacrum is here, right? Your crista is here. So if you do a like most do, like you mark here and then you draw a line, then you're way below where your conus starts, and even higher up is where the medulla starts, right? So it's really important that you're not afraid to do it, either to do a lumbar puncture here or even in the level above, right? Because that's usually how you'll manage it. People usually go too low, and that's where it's hard to do them. Okay. What I also wanted to tell you about, just Cauda Equina. This is the Cauda Equina, the horse's tail. This is why it looks like this. A lot of nerves going out here. If you want to read more about the Cauda Equina syndrome and my reasoning for this, you should check out Levy et al. And EMCases episode 26. This is the conclusion of the second part of this lecture, and thank you so much if you've made it this far. What I will do next is go through cases, and this is another point where you might want to take a break. The cases that I've chosen are is something where I will try to go through my approach that I've been trying to teach you, and the Bayesian approach towards this kind of patient group, the undifferentiated patient in the in the emergency department who might have neurological problems. So pause now or stay tuned, and we'll I'll continue this lecture